My name is AK Maheshwaran. I'm a consultant anaesthetist based in Leicester, and I'm also the clinical lead for the One NHS Finance programme. So to give a bit of background, the purpose of today is to give you an overview and a simplification of some of the elements of and how the finance system works in the NHS. We're going to start quite big and broad and then hone it in down to more specific stuff later on this afternoon when we go through business cases, budgets and spreadsheets, and PLICs and costing, things like that. Most of what we're talking about is at national scale, in that every system has slight differences. Every organisation will have slightly different processes and systems in place. But what we're going to be talking about is broad concepts and things that you can apply within your systems and your organisations. So I'm going to be kicking us off today, and I will share my screen. Bit of sound. So we're going to start with an introduction. So as I said, this is about navigating the healthcare system. It's not about making you into accountants. It's not about cost cutting. It is about allowing you or giving you the kind of knowledge to make the best use of the resources that you have. And we all know we work in a finance system with limited resources and we can't do all the things that we want to do. And it's how we can identify areas where we can make improvements, potentially save money, but actually improve quality. But then to be able to use those finances and to improve the care that we deliver. That's the purpose of today. It is all about being clinically driven. So the clinical drivers will be the forefront of whatever decision we make, but being aware of the financial consequences and being aware of everything that underpins what we do. Every decision that we make has financial consequences, and so we just need to be aware of those and how we can best make those decisions within and use the information that we have available to do that. So one of the things that we're going to be talking about today is a lot is getting best value. So we talk about value in healthcare. And I normally I'm trying to make this a bit more interactive, but I think with over 100 people on this call, I think that'll be quite difficult. But I just want you to take a minute to think about what value in healthcare means for you. What do you think the definition of it is? And what does that actually mean in real life? So there are three types of value that are kind of mooted, are commonly used. There's something called allocative value, which is how you divide up the resources that you have. So that can be at national level, it can be at system level, and to a certain degree, it can be at organizational level. So it's dividing up things, allocating them. It's also called economic value. For most of us, what we mean when we mean value is how we make best use of the resources that we have. And so that's called technical value, and we'll go into that in a bit more detail in a second. Also called efficient value. And the final one is an important one that's often overlooked, and it's called personalized value. And that's to understand that what I value is different to what you value, it may be different to what patients value. We all often have shared goals, but actually our values that underpin them may be different. A couple of examples of that. So one of the big value-based healthcare drivers in the world is the Virginia Mason Institute in America. They did some work with a health board in Wales, where they looked at priorities for healthcare within a small setting. So it was a neurology outpatients clinic. So people with brain disorders, and they asked the patients what they wanted out of their appointments, and they asked the clinicians what they wanted at their appointments. And the clinicians wanted to diagnose the condition, they wanted to prevent disease progression, they wanted to treat the conditions. And the patients wanted better sleep, they wanted to feel less tired, they wanted to be able to function and do the things they want to do in their life. And often those two aims, that the clinician's aims and the patient's aims, align, but there may be times where they're different. From my own personal experience, so as an anaesthetist, I see patients for high-risk operations, and you tell patients about their cancer operations, and there are some patients that that just the thought of having the cancer, irrespective or the pain they're in or whatever situation they're in, means that however high the risk, they're willing to take that because of the impact it's having on their lives, and that cancer, they want the cancer out. There are other patients on the other end of the spectrum that when I tell them that there's a chance that they may not be able to walk their dogs, or they may not be able to live in their own home, potentially at least for a year, they kind of say, oh, I value the quality of my life. That is the most important thing for me, and they choose not to have the operation. So there is a balance that people have to have, and everybody's values are different. And so that's an appreciation that value means to things. Different people value different things. And there is no one size fits all in terms of personalized value. So to focus more on that efficient technical value, I'm going to make it into an equation because it is a finance talk. There are two ways of doing this, and there's different people have different definitions, but the one that's used in the NHS, and it's been used as part of the NHS Constitution and in aspects of the legislation, is that value equals quality over cost. Okay. And quality can be broken down into different categories. There's clinical outcomes. And it's important to note that when they talk about clinical outcomes in this context, there is no specific outcome that we're talking about. There is no specific measure. It could be complications rate, it could be mortality, it could be length of stay, it could be any one of a host of outcomes that you could be measuring. And that's important to note. Patient experience and patient safety. One of the things that people often mention is it has no mention of staff satisfaction or staffing levels. I think when this was first mooted, this equation was created, it wasn't as big an issue, but it certainly would fall under the guise of patient experience and patient safety. So both staff morale and staffing numbers will come under will affect your experience and safety. So I think it can affect those in different ways. And then costs are broadly divided into two concepts, and this is something that's used across the NHS, across finance sectors, and it's revenue costs, which are your day-to-day spend, so your ongoing day-to-day spend, and your capital costs, which are big one-off purchases. Building new buildings, purchasing CT scanners, purchasing bits of equipment that are one-off costs rather than ongoing costs. Now, the reason I put this equation in there is that Michael Porter is a Harvard business professor that first came up with this concept. There are two ways of looking at it. There is the when you have to justify an expense, or you're trying to look at whether something offers value, that the improvement in quality has to reduce the costs. Okay. The other way of looking at it is that the other aspect of this is that improvements in quality will always reduce costs. The problem we have in the NHS and in general in healthcare is that we're very focused on our own costs. So the improvement in quality that you produce by whatever intervention you do may not reduce your department's costs. It may not reduce your directorate's costs. It may not even reduce your hospital's costs. may not even reduce your kind of ICB's cost, your area's costs, because some quality moves will impact on primary care, some impact will be societal benefits, and increasingly there's a concept of environmental benefits and other costs that are reduced. So whilst it's true, improvements in quality will always reduce costs, there may not be the cost that we value, but that we place importance on. And certainly in the past, we haven't placed importance on societal costs and environmental costs, but that is changing. And the other thing it doesn't do is there's no specific timeline for this concept. An example, and I'm apologizing because a lot of my examples are from my own experience, so therefore they are surgical or anaesthetically based concepts. But I'll try and keep it in an understandable form. So what my surgical colleagues, when they do big cuts in the abdomen to do operations, more recently they've developed a new way of closing the abdomen, and it takes an extra half an hour, which impacts on theatre utilization and all the kind of productivity metrics that we use. And it doesn't impact their length of stay. It doesn't impact their mortality. It doesn't affect their 30-day readmission. It doesn't affect any of the main metrics that we use to measure outcomes. But what it does do is reduce the incidence of a hernia occurring where that wound is. So it's an incisional hernia. Where the incision was, you can get hernias, and they can be really quite complex and difficult to repair. But they often occur 5, 10, 15 years after the original operation. So if you were to look at it using our standard metrics, you would show no benefit, but only show detriment because it impacts on theatre utilization and productivity. But you can show that the actual over 10, 20 years, it has a massive impact because it reduces your rate of incisional hernia by quite a large number, like 50, 60%. And if you think about the length of stay, the cost of admission, the cost of potential, if there's any problems with that can be a significant cost saving. So it is working out the right outcome to demonstrate the value of your intervention. Okay, so moving on to a slightly broader subject now, we're going to cover how the NHS structure, how the money flows within that system, and payment systems. So the NHS was created in 1948. It was whilst it was created, it was never an organised, completely organised system. They just brought in the hospitals and services that were providing healthcare under the national umbrella, and it ran out of money within the first year. And it's been through various reorganisations since then. So in 1962, there was a hospital plan which tried to build a district general hospital for every 125,000 of the population. So there'd be a hospital serving that population, and they ran out of money. And various other interventions have happened. In 1974, you had the introduction of health authorities. In 1990, there was this concept of internal market where organisations were competing against each other for work under the capitalism kind of driver, where the thinking was that by increasing competition, you improve quality, but also reduce cost, which may have worked for a little bit, but ultimately has been shown not to be that useful in the current situations. In 2000, there's the NHS plan. The last big major reorganisation were the Health and Social Care Act in 2012, also known as Lansbury reforms, where they did wholesale changes. Now, what happened there was that between the kind of reforms being thought of and kind of the concepts being designed and the implementation for 4 years later, you had the massive financial crisis across the world, which affected funding and affected tax revenues and all these other things. So that by the time it was actually implemented, it was implemented in a much different, in a very different way to what was envisaged. And as with a lot of things in the NHS, the original idea might have been quite good, but how it was implemented often is what leads it to fail. Since 2012, the NHS has manoeuvred itself within the legal framework to try and mitigate against some of the problems that the 2012 reforms caused, until the 2022 Health and Care Act was passed, which wasn't anything. There was nothing dramatic in that Health and Care Act. A lot of it was to do with just tidying up some of the legislation that that the lands reforms had initiated, but the NHS had manoeuvred through, and I'll talk about that in a second. But we're going to talk briefly about how money flows and through the NHS. I'm going to play a video which kind of sums it up in a much more eloquent way than I could talk to you about it. But essentially, it's the Treasury that controls the money that the NHS gets, and it's determined by the spending review, which is then altered by the budget report every year. Where's that video gone? Okay, we'll come back to that in a second. So the Department of Health and Social Care funds the is the body in charge of health in England. So health is a devolved concept, so it is only responsible and funds health in healthcare in England. It's called the Department of Health and Social Care, but social care is still funded by the local authorities. Okay. There are a number of bodies that are funded by the Department of Health and Social Care. So I'm going to stop sharing, and primarily just to make it a little bit interactive. And I'm going to ask if anybody can name some of those bodies. So there are, as I said, I think there are 12 or 13 bodies that are funded by the Department of Health and Social Care. How many can we name? So NHS England, okay, that's the easy one. CQC, yeah. ICBs indirectly, we'll talk about that in a second. NIHR is not, strictly speaking, it's not funded as a body directly by the NHS, by the Department of Health and Social Care. So Public Health England doesn't exist anymore, and it's now called the UK Health Security Agency. NHS Employers is a so umbrella group for the kind of the providers, and so they're not funded. They're funded by the providers rather than by the Department of Health and Social Care. So it doesn't have a budget per se. Health Ombudsman, no, that's done through parliamentary. It's a parliamentary and health ombudsman, so it's funded slightly differently. NHS Digital doesn't exist anymore. You were right until earlier this year, and so NHS Digital has been absorbed into NHS England. CCGs no longer exist. They're called ICBs, and I'll talk about those in a second. NHS E&I, well, the I bit's been taken off, and I'll talk about that in a second, because that's part of the cleanup that happened earlier on this year. It's now just NHS England. HSSIB, yes. NHS Business Services, yes. HEE doesn't exist anymore. The Pension Authority is the shared business services. NHS Property, no, that's almost a kind of an arm. It's a separate company that's owned by the NHS. MHRA, nice. Yeah, GMC and NMC are not. They are separate, completely separate bodies. Supply chain again is a company that it's owned by the NHS and often in partnership with another company. At the moment, I think it's DHL. The Counter Fraud Authority, yes. So I think we've got a fair number. Health Research Authority, yes. So share my screen again. So the answer there. So I've divided them up into their official designations, but they're essentially very similar. It's just a question of how much control the Department of Health and Social Care has. So you have the executive agencies, which are medicine, MHRA, responsible for vaccines and the kind of approval of medicines and products. You've got the Health Security Agency, which was formerly Public Health England. You've got NHS Blood and Transplant, you've got the Business Services Authority, you've got NHS Resolution, which is the litigation authority, essentially, the new name for the litigation authority, that looks after the indemnity plan and deals with the kind of legal aspects of things. They also have an increasing role in patient safety initiatives. They provide some funding for patient safety stuff. And you have the Counter Fraud Authority. So of those, some of those are England only. A number of them increasingly are UK-wide. So NHS Blood and Transplant, MHRA, and the UK Health Security Agency now increasingly have UK-wide remits rather than just England. And then you have your commissioners, which is now just NHS England. You have NICE, National Institute of Health and Care Excellence. So Health Education England and NHS Digital no longer exist as separate entities. They have been absorbed into NHS England. So NHS Digital is part of their NHS England's digital strategy group. And Health Education England is within the NHS England workforce team. Then you have lots of regulators. Some are general, like the Care Quality Commission, and then you've got some more niche ones like the Human Fertilisation and Embryology Authority, the Human Tissue Authority, the Health Research Authority, and then the new one that has recently got statutory footing is the Health Services Safety Investigations Body. Okay, so I'm going to play a video. Please let me know if you don't hear the sound. I think I've shared sound. Actually, I'm not sure I did. Let me just, if you hear sound, let me know. If you don't hear sound, let me know. I'm hoping you can, this summarizes a lot of what I've said.
This animation gives an overview of the structure of the NHS in England and describes how the money flows. How public money is spent is determined by Parliament, and more specifically, the Chancellor of the Exchequer. Money allocated to healthcare is determined by the Spending Review, which is usually every 3 years, and amended annually by the Budget Report. The government department responsible for healthcare is the Department of Health and Social Care, which has the largest amount of pre-allocated public money, with an annual budget for 2023 to 24 of £188 billion. This is divided into £176 billion of revenue funding to cover day-to-day running costs, such as staff salaries and medicines, and £12 billion of capital funding to pay for infrastructure and maintenance costs. Health is a devolved function, so this funding is only for healthcare in England, as social care is funded separately via local authorities. From the budget, the Department of Health and Social Care has to pay its internal costs and fund several executive agencies, special health authorities and arm's-length bodies. The biggest of which is NHS England, which legally merged with NHS Improvement on the 1st of July 2022 as part of the Health and Care Bill. NHS England has now also merged with NHS Digital and Health Education England. NHS England received the majority of the Department of Health budget, with funding for 2023 to 24 of £160 billion. NHS England works via 7 regional teams to support the delivery of the NHS long-term plan. The plan was published in 2019 and outlines the key ambitions for the health service for the next 10 years. To create a service fit for the future and get the most value for patients out of every taxpayer pound. The Health and Care Bill builds on the long-term plan to support integration. NHS England has a budget of £27 billion for directly commissioning services, including some primary care services and public health. It directly commissions military healthcare, health services in the justice system, for healthcare for children, young people and adults across secure and detained settings, and specialised services. There are 154 directly commissioned specialised services, which are grouped into 6 programmes of care: internal medicine, cancer care, the trauma programme, women and children, blood and infection services, and mental health. Over the next few years, NHS England will delegate some of its commissioning responsibilities to local commissioners, with pharmacy, ophthalmology and dentistry services fully delegated by 2023. 9 regional committees are being created to commission specialised services from April 2023. They are joint committees between NHS England and the relevant integrated care systems in each region. Following several years of locally led development, 42 integrated care systems, ICSs, were established on a statutory basis on the 1st of July 2022 as part of the Health and Care Bill. Integrated care systems have 4 main purposes. They bring partner organisations together to improve outcomes in population health and healthcare, tackle inequalities in outcomes, experience and access, enhance productivity and value for money, help the NHS support broader social and economic development. The new ICS are led by an Integrated Care Board, ICB, and an Integrated Care Partnership, ICP. The exact composition of both the ICB and ICP will vary between areas, but as a minimum, the Integrated Care Board will include a chair, the CEO, and representatives from NHS providers, general practice, and local authorities. ICBs replaced clinical commissioning groups, CCGs, and are now responsible for developing a plan for meeting the population's health needs, managing the NHS budget, and arranging for the provision of health services in the integrated care system. The majority of NHS England's budget, £107.8 billion, is allocated to ICBs for commissioning local health services. ICBs plan and commission services for their patients. The Integrated Care Partnership will also include the ICB CEO, local authority representatives and NHS providers, but may also include representation from other organisations. The Health and Care Act has seen a shift to more strategic commissioning and a more collaborative approach to planning care. Allocations are made from NHS England to ICBs as a system funding envelope. ICBs will have the flexibility to manage resources within this envelope to deliver agreed local priorities. ICBs will agree on contracts with providers, with increases expected to be based on aligned payments and incentive basis. Organisations within ICSs have to adopt and adhere to a shared control total, which in effect binds them to meeting a collective target for financial performance. So, in summary, money flows from Parliament via the Department of Health to NHS England, and in the most part, integrated care boards to the organisations that provide patient care.
So just to kind of go through that again a little bit, that's right, missed all this. So when we talk about shared control totals, that's basically a control total is an agreement with the Department of Health or NHS England as to your underspend, overspend, your budget. Essentially, is it going to be are you going to be over budget? Are you going to be under budget in terms of your kind of financial turn at the end of the financial year? And a shared control total means that across your ICB, you have to agree what it's going to be, and often it's a net zero type thing. But in certain ICBs, there may be a planned deficit or a planned surplus as your target. That's your control totals. But just to kind of illustrate what's been happening with the budgets over the last few years and predicted for the future, but that may obviously change with changes in policy and the potential general election coming next year, is that overall the budget, when they talk about protecting the NHS budget, politicians primarily mean protecting the NHS England budget rather than the overall Department of Health and Social Care budget. And so what that has led to is that generally what happens is that NHS England's budget either stays the same or goes up and is protected, but your capital budgets and your Department of Health and Social Care budget, so the funding for all those other organisations apart from NHS England, have been cut. One of the worst hit budgets was the Health Education England budget previously, because that covered a lot of the training posts and the bursaries and all those kind of things that were particularly underfunded and had to be cut. So one of the multitude of reasons for bringing Health Education England into the NHS England kind of body is to protect their budget a little bit more. And you'll find that as the Treasury tightens its coffers from the lack of tax because of income, they'll be more reluctant to give funding to NHS England, which in turn means that funding that is necessary will then have to come from the Department of Health and Social Care's budget and the capital budget, if absolutely necessary. It has happened in the past, so not only before COVID, but a few years before that, whenever NHS England or the providers, so the organisations within NHS England, went over budget, and they often did significantly, they ended up using the capital budget to plug that hole, because the Department of Health and Social Care as a body is not allowed to overspend. So that's what's happened in the past. And so you can see that bodies like the Care Quality Commission, like Health Education England in the past, and NHS Digital in the past, and some of these other bodies have had their budgets massively squeezed in order to protect the delivery of frontline services, which we've also been restricted in that way as well. Just to go back through this, sorry, just to briefly cover the Health and Care Act in a little bit more detail. So it was based on a white paper in early February 2021, which and it received royal assent in 2022 and became effective then. But it essentially was all of this was based on something that the NHS England put forward to Department of Health and Social Care back in 2019 of what it wanted out of legislation to tidy things up. And essentially it put into statute the previous STPs, so Sustainability and Transformation Partnerships. They became called ICBs or ICSs. The key things were actually removing the obligation. So part of the Lansley reforms and previously was that when you were commissioning, you were obliged, you were mandated to put the services out for tender. So you had to invite competition between different organisations to provide the service, and it didn't really work. And what has happened now is that requirement has been removed. Now, the ICSs, the ICBs can put out things to tender if they wish, but they are not obliged to. The other thing that they've put into it is a duty to collaborate. So you are obliged to kind of work together within organisations. They are you'll see a flurry of joint appointments and joint committees. Whilst they were in existence pre this legislation, they were often workarounds. But now you are allowed joint appointments and joint committees between organisations that even are potentially competitive ones as well. So that was the biggest drawback previously. The other main thing was a lot of tidying up. So we talk about NHS improvement, which was the kind of regulator, with NHS England being the commissioner. NHS improvement never really existed as a separate body. It was still officially two different bodies. It was the Trust Development Authority and Monitor. Now this is historical, based on back in the day when they were encouraging provider trusts to become foundation trusts, and Monitor was set up to oversee these foundation trusts, and the Trust Development Authority was there to help the other remaining trusts become foundation trusts. And after a few years, they realised that that wasn't the best way forward, and being a foundation trust wasn't the guarantee of good governance that they were expecting. And so those two merged once they stopped pushing for foundation trusts to become NHS improvement, but they still existed in reality. And then what you also found is that NHS England and NHS improvement, one was a commissioner, one was a regulator, gave mixed messages. So one would say you have to provide safer staffing, and the other one would say you can't afford to provide safer staffing. And and provider organisations were under a lot of stuck between a rock and a hard place, because they got mixed messages from their different bodies that oversaw them. And so a few years ago, they merged with be NHS England and Improvement, but they officially existed as three separate bodies. But the legal framework has all been tidied up, and now you've just got one body that's responsible for the NHS in England, which is NHS England. I hope that makes sense. The final thing that was added in is, so NHS England, when it was first set up as part of the Lansbury reforms, were designed to be an arm's length body with not quite independent, but with a much greater degree of independence from the government. But that's been reined back a bit. So the legislation has increased the power of the Secretary of State for Health and Social Care to oversee and intervene within the NHS, within NHS England. And that's probably the most controversial aspect of this bill. Very finally, I've got 10 minutes to cover payment systems in the NHS. So some of the stuff that you'll hear today will be, there'll be a lot of overlap, and it's trying to not just repeat, but trying to explain it in different ways from different perspectives, so that you can understand it. But essentially, how services are paid for in the NHS is constantly changing. And they've tried various different payment systems. And so what I'm going to start by doing is putting to kind of highlighting the building blocks of what are the possibilities. So every payment system in the world, in terms of paying for healthcare, is based on a combination, one or a combination of these different building blocks. So the first one is a block payment, and that's where you have a lump sum, so a fixed amount, to cover a specific range of services. And a true block payment doesn't matter. Once you've determined that this is the amount that you're going to pay, it doesn't actually depend. It's not affected by what you actually deliver. Okay, so it doesn't matter about the quantity of demand or supply, and it's traditionally used for services that are difficult to measure their quantity. You can't, so like community services. It was also what was used during times of uncertainty. So during the COVID pandemic, block contracts were used. When people needed predictability, they wanted certainty as to how much money people were spending and how much money people were receiving, then block contracts were the default. But the the problem with block contracts is if you over deliver. So if me as somebody working for a provider organization, if my department over delivers, we get no more money. But if we under deliver, then the commissioners are not getting value for money. They're not getting the best value for their services because they're overpaying. So it has some drawbacks as well. The next one is capitation. So a capitation is a lump sum payment to this based on the size and complexity of a population. So it's how the funding for ICBs is determined. It's how the funding for the kind of Scottish health boards and the Welsh health boards. It's also the main method of payment for primary care for GP services for their bulk of their money. Obviously, they have other extra components, but the bulk of their money is from this capitation concept. And there's going to be a further talk on the funding of primary care later on. But essentially, the size is a per person thing, but that population is adjusted depending on the complexity. And that's where the controversy is and where the differences are, because it's different factors are taken into account and different factors are weighted differently. In terms of, and it could be age, it could be demographics, it could be socioeconomics. There's various things that could be taken into account when you're kind of adjusting your capitation population. Pathway of care was going to be really popular and was a few years ago was going to be spread widely rolled out, but it's kind of gone out of fashion for the moment. It was how hospital maternity services were covered. I mean, basically, it's you get paid for a whole pathway. So in this case, hospital maternity services, you got paid, when you're pregnant and you're booked into by the GP into the hospital maternity services, the hospital or the lead provider would get a payment for antenatal care. You get separate payment for intrapartum care, and you get separate payment for postnatal care. And you have different levels of complexity. And it was one of the ideas in the past was to have a similar kind of concept for hip replacements or joint replacements, where from the point of referral till all the way through kind of optimization, prehabilitation, operation, rehabilitation at the end, discharged from the whole system would be one payment. And then the lead provider would then subcontract out various aspects of that pathway. It never caught on, primarily because the different elements of the pathway, as your complexity changed, you didn't really move up. You didn't get more money until you entered the next stage of the pathway. So it kind of wasn't really cost effective for many organizations. Pay performance is a kind of key part of every contract. So in primary care, it's the quality for outcomes framework. Again, it's a payment based on achieving certain numerous metrics, and the same thing for quality commissioning for quality and innovation. So sequins in acute and community mental health services. You have national sequins, you have local sequins. They've decreased in value to a much smaller percentage of the contract value. They used to be 2.5%. Now I believe they're 1.25%, 1.25% of the contract value. So still significant, but certainly not as big as they used to be. And there are other performance metrics that are incentivized in different ways. So per diem is not really used very much in this country, but it is used in lots of other parts of the world, where you get lump sum payment per patient per day of care, and that can be you get level 1 payment for kind of ward-based care. You get a different payment for slightly enhanced care, HDU care, ITU care. You get different levels depending on their acuity, but it's a lump sum payment. The most common one that's being used internationally now and is used for elective care in this country is the case-based or activity-based reimbursement. So the more work you do, the more money you get. It used to be called payment by results, and it's still referred to as payment by results, but essentially it's a case-based or activity-based payment system. It's used in acute and mental health services for elective care, and I'll talk about it in a minute. But essentially, you have your diagnosis, you have your comorbidities, and you have any treatments or procedures that are carried out. They put into a into a software program, and you get a healthcare resource group, which is basically a way of coding the data that puts together kind of things that cost a similar amount to deliver, essentially. And the tariffs are often based on those HRG groups. And then the final one is pass-through payments. So for very specialized work, or for high-cost chemotherapy drugs, or things that are very expensive, the cost of the service delivery, or the cost of the drug, is paid for directly in full by the commissioning body. Okay, so they are the kind of the 7 building blocks of what a payment system looks like. The current payment system that's being used this year and will be used next year is something called the Aligned Payments and Incentive System. And essentially, you have a fixed element, which is an agreed level of acute acuity. So this is used across the board, and the fixed element is for the kind of emergency or acute work. So acute activity, maternity, mental health, community and ambulance services. It includes your expected, the BPT is the best practice tariff. So you have your baseline tariff, and if you achieve a certain number of markers, which are deemed best practice, then you get slightly higher rates. So you in the fixed element, you include that higher rate, and you include the sequin achievement. The CNST is your clinical negligence scheme contributions. So it's your indemnity contributions. And various other things that are included in this fixed element. And then it's very similar to a block component based on your kind of previous data on what you've been delivering. And the variable element is your elective care. So this is where the activity-based, case-based stuff comes in. So elective, ordinary and day case, outpatient procedures that have the NHS payment system price, so have a tariff attached to it. First tenders, diagnostic imaging that's not included in a baseline tariff, and other things like that are included in this variable element. So that's very much based on how much you're doing. And then there's other bit that's adjusted based on whether you achieve the best practice tariff and sequence. So this is for all the major contracts, contracts that are small in value. So if if you have a small amount of work that gets done in a neighbouring trust or in a neighbouring ICB or another part of the country, that's excluded, and that's under a small volume activity contract. So that is me in a nutshell. That is a very, very quick and very broad overview of how the NHS funding works, the money flow through it, and a little bit about how we get payment systems. There'll be some more information on commissioning and how that works in the next talk, and hopefully there'll be some repetition of some of what I've said to help you explain it a little bit more and understand it. Feel free to email me any questions. Feel free to ask any questions, but if you want to email me anything, that's also very welcome to. You'll get the slides sent out to you. The animation is freely available on our YouTube channel if you want to look at it again and see. So I'll take a couple of minutes for questions. I've amazingly run to time, which doesn't often happen. So if you have any questions, please feel free to ask. If not, you can either email me at my full name at my UHL at my nhs.net email address, or because my name's long, the easiest one you can email me is my short name. No questions. I'll be around most of the day. So if you do have questions before the break, in the break, I'm also doing business cases right at the end of the day. If you're hanging around that long, if you want to ask any questions, feel free. Oh, Kimberly.
Hi, sorry. Just a quick one. I don't even know if you know the answer to this. You said with the like the per diem payment systems that we don't really do it around like England. Is there a reason for that? Is there a reason that we don't have those payments and others do?
It's just, I think that it's to do with the healthcare systems. It is one of the ways that you can pay for systems. So I think it has been used in the past for things like what's called excess bed days. So when you have your tariff, you get a set amount of bed days that a predicted length of stay, and above that you get extra payments. Now, I'm not a finance expert. I've an understanding of this, but some of the other speakers today might be able to help answer that. But I don't know if there's a specific reason for that. I think it's just, it's not a very there's no finesse in that, to be honest.
Yeah,
it's not a very cost effective. It's an arbitrary number, and I think in places where the data isn't as good, so it's often used in less developed healthcare systems, essentially per diem system.
Yeah, that makes sense.
Whereas actually you want a bit more finesse in in working out how much something costs versus how much you get paid for it, because what you'll often find with the per diem, you lose money on it, because essentially for most places you will spend more to deliver that healthcare than you'll get paid for it.
Okay, lovely. All right, thank you very much.
That's generally why we don't use it.
Yeah, that makes sense. Thank you very much.
No problem. So it doesn't look like any more questions. So I am going to introduce Anthony Brown, who's the Director of Finance Strategic Commissioning at NHS North Central London ICB. Is that right?
Thanks. Okay. Yes, that's a bit of a mouthful, isn't it? And hopefully some of that will become clear in the presentation. Just to reflect on what we've just heard, I thought that was an excellent introduction into finance in the NHS, and strongly encourage you to go back over the slides as well, including the video, because they are really useful resources. And for me, someone who likes visual learning, I've got a video in my presentation that we'll send around as well, and they're always a useful aid memoir to come back to if you forget some of the details. So I will try to share my slides on the screen from the beginning. Hopefully they're working. Can people see that? I'm going to assume that silence means that everyone can see what I've got in front of me. So, some slides on introduction into commissioning in the NHS. I won't be able to see people's hands going up during the presentation. So what I'll do, like AK did, is I'll work through the presentation and then I'll try and take some questions at the end. And as per AK, I've left my email address on the front of this, so you can contact me with any questions afterwards. I'm happy to oblige. We're all working for the same team after all, so if I can impart some knowledge on commissioning or any other part of finance, then happy to do so. So in terms of my background, I've worked across health and social care finance for 20 plus years, roughly 50-50 across both, and been sort of front and centre, I guess, in terms of some of the changes in the NHS commissioning landscape during this time. My challenge in terms of this presentation really is to provide you with something that's hopefully engaging, and I'm also acutely aware that I stand between you and a coffee break, so I'm going to crack on with the presentation on that note. So firstly, I suppose, what is commissioning overall, and what do we mean by this term? So commissioning really is just the continual process of planning, purchasing and monitoring services. So in this case, in the NHS, we tend to operate on an annual basis. Oh, excuse me. Tend to operate on an annual basis and assess the health and care needs of our local population, which then helps us to plan and purchase care on behalf of our local residents. I think the blue wheel here gives a fairly good indication of how this all fits together. So if you're a visual person, like I said, like me, you can see that it's a cyclical process, and one stage of commissioning leads on to the other. So looking at what we need, measuring the priorities, and then going out and effectively buying services in from different providers across the health and care landscape. So that might be buying in services from trusts, buying in services from local authorities. The most important part of this wheel, I think, is right at the centre is the patient. So everything we do should be to benefit patient care and the patient outcome. You might be thinking, actually, from all this as well, that your organisation is a commissioning organisation as well. And in part, I suppose you'd be right, because You might outsource services, for example, diagnostic services from your trust might be outsourced to a private provider. You might be bringing in IT services at general practice, etc. So today, just to distinguish between all of these things, I'm going to be talking about the main commissioning bodies that exist within the NHS framework. So the major players within commissioning, so who are they? Well, there's three really on the pitch at present, and I'll work you through each of them in no particular order, but these are NHS England are our parent organisation. So let's go first with them. They are the so I've got some noise coming through, so if you could mute if possible, please. Thanks very much. So NHS England are the commissioners of specialist services. So if you think of things like neonatal critical care, cystic fibrosis, for example, transplant services, that's NHS England buying those in on behalf of usually a region or a national level if they're extremely specialised. NHS England also buying some public health services, so thinking screening and immunisation services. And they also are responsible for services such as forensic mental health. So to give you an idea of scale, it's across the country, it's about £25 billion worth of specialist services, for example, that NHS England buy in for healthcare. Next up, then, we have local authorities, and local authorities, as the name suggests, commission services on behalf of a local borough or council. I think AK has already said that by and large, this is separate to NHS funding, and they commission social care services as the bulk of their work. However, within the NHS, they also commission services for sexual health and things like school nursing and substance misuse. And last but not least, the organisation that I work for, the Integrated Commissioning Board. We've got circa 40, I think it's 42 at last count, of integrated commissioning boards across England. And they're responsible basically for everything that is not picked up by NHS England and the local authorities. So the vast bulk of commissioning takes place via the integrated care boards. So think acute, community, mental health and delegated services such as primary care. We also work with non-NHS organisations, so we buy in services from the voluntary sector, from the independent sector, and from the local authority. We work very closely with them in terms of things like discharge commissioning, and obviously then not only providing acute and mental health, but services such as prescribing and continuing healthcare. The ICB of late has also been given responsibility for primary care commissioning. In fact, I think that was in 2015, so it's probably not new news anymore. And you're all very familiar, I'm sure, with your ICB if you work in primary care, and have also taken on dental, optometry and pharmacy services on behalf of NHS England. And what you will see is more and more services, specifically specialist services in NHS England, being delegated down to the integrated commissioning boards. So I think AK has already shown you part of this, and it summed up his video. So I'll just open up the slide entirely because I just want to land a point around kind of what on earth the system looks like. And there's lots of acronyms in the NHS, and I'll give you a jargon buster at the end, hopefully that will give you a clue to what I'm talking about. But the ICB itself is an organisation made up of mainly I suppose back office and commissioning that sits within an ICS. So if you think of an ICS, an integrated care system, as something which is a collection of different organisations, all responsible for planning the health and care needs of a particular geographical area, the ICB is the organisation, the hub organisation that sits within that. So to give you an example, in my system, in my ICS in North Central London, we've got 10 NHS trusts, 5 councils, local GPs and the NCL Integrated Commissioning Board, and they all operate within the integrated care system in North Central London. The ICB then is responsible for commissioning of services to meet the health and care needs of its local population. So we focus in the ICB on residents in North Central London, and we're accountable, as the diagram suggests there, to NHS England, who provide us with our funding, and you would have seen that on the video that AK shared previously. You'll also see later on in the slide deck that NHS England also acts as our main regulator, and they measure our clinical and financial performance, and that's both across the ICB and the ICS as well, including the individual trusts that make up the ICS. So as I've mentioned, I've left in a video here. I think we're probably going to be short on time. I'm keen for you to get your break. I won't go through it. It's only 5 minutes long in total. It's not the brand spanking new version of the King's Fund report here, but it's still relevant, and it's still really useful if you want to understand how the ICS and the ICBs are formed and their makeup. So I'll invite you to take a look at that in your own time. Moving on then to the point I really wanted to land from the video is the fact, and mentioned by AK, that we're on a journey of constant reform. So on AK's slide, we talked about the embryonic health service of 1948 and how that's developed to present day. I've gone from a potted history here in 2013, which is when the Landsea reforms kicked in, to 2023, which is obviously present day. I think that the key part for me here, being an accountant, I'll gravitate towards the numbers. We've got 211 clinical commissioning groups in existence in 2013 on the left-hand side of the slide, and that shrinks down to 42 integrated commissioning boards in 2022. So what that tells you, really, not that organisations that commission services have disappeared, but really they've just merged and they cover larger geographical areas. So again, in North Central London, we've moved from 5 CCGs or clinical commissioning groups in 2020 to 1 ICB or Integrated Care Board, which sits within an integrated care system in July 2022. The key part of the reform, really, or the most recent reform in the Health and Care Act, has been the shared responsibility of the delivery of health and care services. So we've seen much more focus on system working, and the infrastructure around the Act has allowed us to work as a system more easily without problems around regulation or conflicts of interest, although they still do exist. In finance, to put this into practice, what we've got is the responsibility to deliver both a balanced financial position at each individual organisation level and also at a system or ICS level. So looking at the role of the integrated care systems in England, I've pinched this map, but I've not done a very good job in pinching it because I think it's slightly out of date, because it clearly shows, if I'm telling you that there's 42 systems, Devon and Cornwall have let me down being labelled as 43 and 44 systems in the country. What's happened, obviously, since is the fact that we're still merging. So the creation of the 42 ICSs here means that we've shrunk down by 2 in terms of coming together to form ICSs. The colours on the map, so what do they mean? They represent the 7 regional NHS England teams that are responsible for oversight across each ICS in their region. So if you were to look through, you'd hopefully see your own system. North Central London sits as you would expect in London. We're number 8 on the slide, up in the middle there, and there's 4 other ICSs in London, making up a total of 5 for the London region, which is that sort of burgundy colour at the bottom right of the map. The 4 main aims of the ICS are listed on the slide as well, and by and large it's focused on improving outcomes with a huge amount of focus on population health management. The strategy that ICSs are also required to follow requires an addressing of health inequalities, so looking at access to healthcare services and variation in patient outcomes. And we also are required to support the broader social and economic development in the country. So in lay or simple terms, that means how healthcare services can contribute to lowering unemployment rates, for example, addressing health and well-being, or things such as the green agenda and net zero targets, for example. The part that I'm most involved with is the third aim on the list, of course, finance support delivery across healthcare. However, the enhanced productivity and value for money is something that we are most involved with, and balancing the financial position is the absolute must for finance professionals in the NHS. So moving on then to something around the strategy for the ICS. This is pinched from the North Central London ICS, but it will be similar to your integrated care systems that you sit within. It really sets out the challenge where we're moving from a collection of health and care organisations that operate in silos, or mainly or were operating rather in silos in perhaps an uncoordinated way, to system thinking that focuses on population health and the benefit of residents. I've highlighted here a few key words which I think are consistent throughout all ICS plans, so prevention, integrated care, and a focus on how we collectively understand and address the wider determinants of health. The key is ensuring that patients can live more of their life in good health, and you'll see that reflected across many ICS strategies. Obviously, also we're in terms of that regulation piece, this is the NHS England plan on the page for 23-24. So it sets out the targets and ambition that all the ICSs need to collectively move towards. And so the local objectives align to national targets as well. You'll probably likely recognise some of these from your own day jobs, or even just having read them in the news. Reducing waiting lists, improving access to GPs, improving access to mental health services, so crisis IAP services, etc. And in future years, you can expect a continued focus on productivity, again, waiting list reductions, and the NHS workforce challenge. Finance teams tend to support, obviously, across all of these. It's a collective responsibility. Equally, it's the collective responsibility of working on productivity, efficiency, and to the delivery of a balanced financial position, which is target number 7 on the list there. So just moving through to delivery, to give you just an idea of how this works. So generally we segment into 4 areas. So one being person-centred, right through to neighbourhood, place and system. What we're seeing here is really just a breakdown of our patients or residents into smaller cohorts, so we can better identify and address the needs of a particular population. Person-centred obviously is quite clearly focused around an individual's needs, but neighbourhood and place might be newer terms, so I'm just going to explore those slightly further. So neighbourhood level is the smallest level of commissioning. It tends to be between 30 and 50,000, and it's around the primary care delivery. So thinking of GPs, opticians, dentistry, community pharmacy work, servicing their local population. Healthcare professionals then, and so if you work in primary care, you will have already formed part of a primary care network or PCN, and all doctors and healthcare professionals should now be part of these networks, which should be helping to share resources and focus on the delivery of local patient care. Next up, we've got place level. So this is a collection of between 250 and 500,000 people, and in practice it tends to be a borough or local authority area. So the London Borough of Camden, for example, in our patch, it would be deemed a place. Most councils already have health and wellbeing boards, so they will continue to work to provide information at place level for commissioners across health and social care. And at place level also we've become working together to share information to support patient need, and working across things called provider collaboratives, which are usually a collection of NHS provider organisations that work to a single aim. The benefit of working together at place level is obviously that you have a good knowledge of the health inequalities, the needs, the outcomes of your system, or rather of your place, and how to address some of those issues. And finally, system level. So this is in essence the ICS in total, and this is where we start to think about working across several places, and with the population being anywhere between 1 and 3 million. So in North Central London, we have a population of 1.6 million. So the slides here, if you want to come back to them, give you that bit more information about both. I won't go through it. I just want to move on to a bit of an example about how this functions in reality. So here's the North Central London integrated care system. So as I mentioned before, we've got 10 major NHS providers. Brilliantly on the list, it says 12 there, so I can count. There's 2 extra in there from North West London who provide community services for North Central, so we tend to include them because we always get asked about them. We've got 2 apologies, we've got 5 local authorities, which are the colours on the map there, and 33 primary care networks. In terms of the funding that we attract, so from a trust perspective, so there's 10 NHS trusts that I just mentioned. We have a total of £5.6 billion worth of income, and if you think that approximately I think it was 160 billion that AK mentioned was the overall NHS England funding, we represent just under 4% of the national pot. So we're rather small in terms of geographical area, but we do attract slightly more in terms of funding. And I think that starts to land home when you think about the NHS organisations that sit within North Central London, such as Great Ormond Street, Moorfields or UCLH. So they're national centres of excellence, and they tend to attract patients or pull in patients from across London and outside of London, and even at national level. And out of this 5.6 billion that North Central London trusts have as their income, the local ICB only provide 2 billion of that funding. So the rest of that money comes from other ICBs and commissioners across the country. So the ICB doesn't just spend money with these trusts, it's also got responsibility for the health and care needs for the rest of its population that need care outside of a hospital or NHS setting. So thinking there in primary care, things like continuing healthcare, and obviously services that we jointly deliver with the local authority or with the voluntary and independent sector. In total, the pie chart on the table shows that in the North Central London ICB, we spend 3.5 billion on commissioning health and social care, or health and care services rather, for our local population. And in terms of how we work together on this example, we set out a series of financial principles in North Central London. This will be the same in all of your integrated care systems. So how can we work collectively for a shared goal in terms of delivering the best possible care for our patients within our financial constraints? So we use the financial principles to make sure that decision making works in the interest of the system and ultimately the patient, rather than benefiting any single organisation. And in turn, we seek to protect those that think about the system first and mitigate risk if their individual organisation is at risk. So to give a real life example, we've had an elective orthopaedic review across North Central London, moving a lot of our specialist work that attracts more income to our national or regional specialist trust, the Royal National Orthopaedic Hospital in Stanmore, and then the more routine work being retained by our district general hospitals. And what's that meant? That in essence has meant that some of those district general hospitals have lost out on income that they would have otherwise attracted. And obviously to make good that, we've made sure that there's no losers in terms of focusing on what's best for the patient. In short, then, the financial principles help us achieve local aims of financial balance, and also they attend to the fact that our future clinical decision making depends on sound financial bases as well. Then finally, just coming to the end here in terms of the financial regulation, my favourite. We've got a list of things that we're obliged to adhere to. The third one down is probably the one that I'd like you to take away, which is obviously financial balance. I've talked about that a lot, and you'll note that that's across the ICB. So we need to balance in the ICB, and we also need to balance across the ICS. Wider regulation then takes place with NHS England providing oversight. The National Strategic Oversight Framework, or SOF for short, sets out the 6 key aims that NHS England measure us on, and there's a myriad of other information that NHS England look to see to make sure that we're meeting our targets, both within the planning guidance and the long-term plan. This is how they measure us. So from 1 to 4, 1 being the best and 4 being the worst. You definitely don't want to be rated as 4 ideally, which is known as soft 4, so the System Oversight Framework rating of 4. And if you are in soft 4, you can expect a large amount of NHS attention, NHS England attention rather, and the provision of a recovery plan. You might find yourself in this position if there's material issues with your financial plans. So, for example, if you are not delivering your financial plans or are materially off target. So just finally then, to wrap up, I've got a jargon buster here for you. Hopefully I've covered most of the acronyms or initialisms used during my presentation, and I've given you a bit of a description, but if there's anything else that I've missed off there, then feel free to shout. And finally, just recognising the fact that a lot of information here in one go, and it's a bit of a whistle-stop tour. So if you do want to email me with anything outside of the presentation covered today, I'm happy to help and assist, and absolutely we'll have some time for questions now. So I'm just going to try and take the slideshow down as well. So Becky, I haven't been keeping an eye on people with hands up. Hang on, let me see. Amelia, I think you've got your hand up.
Hi there. I found your slides really helpful. I wondered if it's possible to see similar slides for our own ICBs. So I think I'm South West London, for instance.
Okay.
Just where would that be something I could get from them, or would we?
Yes, absolutely. So yeah, I was talking to Helen Jameson, who's your CFO yesterday, in fact, and so yeah, I can ask for those to be sent to you directly, to be quite honest, because you're part of the London patch, so I know your people quite well. But absolutely, can send that through. I think just for other people on the call, just so you don't think we're all London centric here, all of this information will be available from your finance teams either at the ICB, or if you speak to your CFO, your organisation, or your finance representative at your organisation, they will be able to get you similar information, and then it should also be available on your intranet sites. But if you're having any particular problems, then I'll do my best to send that on, and as I we're an adjacent system to Southwest, I can stretch that bit further, Amelia, and ping something over to you.
Thank you.
Anything else from people at all? Becky, I don't think you've got any more questions at the moment. Or AK, thanks for joining back. I'll pass back to you then.
Thank you very much. Thanks for that very informative talk. If you have any questions, again, please feel free to ask them, put them in the chat, or email either Anthony directly or us at NHS Finance, and we can try and help you in any way we can. But if there isn't nothing else, we'll go early to the screen break, and you can grab a quick coffee to keep yourselves awake and fresh for this for the next finance talk on procurement, which Mark Ibbotson is going to be delivering. That'll start back on time at 5:11. So 15-minute screen break. Come back at 11:05. Thank you very much. ask him the question about increasing commissioning for prevention. There is something about, I think there was a shift, there was an attempt to shift stuff towards prevention, but unfortunately the reactivity of the current system is particularly financially heavy in terms of costs. But we'll ask him and get back to you. We have a hand up. Is that Emily? Emily's your hand up, or is that an accident? No. Becky, is Mark on the call?
I can't see him yet, but I've just dropped him an email.
Okay.
Hopefully he should join shortly.
Just while waiting for the next speaker to join the call. So that was... Why is mental health considered more of a local authority responsibility than more centrally? So I'm not sure what that means. I know, so funding for mental health directly in terms of the medical side of things is certainly funded by the ICBs. So it's one of the core bits. I think other aspects of mental health, such as and there's a lot of social aspects of mental health, which are the local health. So social care is very much the responsibility of the local authorities. The kind of grey area is things like drugs and alcohol services and services for local for homelessness and things like that, which is there is much more of a grey area because there are social aspects as well as mental health aspects. In a lot of areas, those services are running they kind of run on a by third sector organisations, so whether they're charities, whether they're kind of community partnerships, a lot of the drug and alcohol services are run by third sector organisations. So I'm not sure that I don't think they're considered more of a local authority as responsible directly. It's that they are probably there are closer links with social care with mental health than there are with the kind of general physical health. Obviously there is an overlap in all areas. Annual operational planning process. So if we think that the financial, just from my very, very basic understanding, so this is a very simplified version, from my understanding, so the financial years run from April to April, and the operational planning guidance, so from NHS England, often comes out in kind of mid-December. So the formal planning guidance comes out in mid-December, which and is formalised in January. But before that, a lot of the data is collected. So if you are looking to increase your services, if you're looking to expand your services, or you think your services are incorrectly funded, you need to get the data in as early as possible. So often provider organisations have their data in and are kind of processing it and cleaning it up kind of in October, November for the following financial year. Before and there's a kind of informal establishment of the operational planning. So in terms of what your demand is, before the actual the intricacies of the planning comes out, if you see what I mean. So the discussions and negotiations happen in the kind of December, January time. but a lot of the data, and from a kind of from a services point of view, the data needs to be in much earlier than that. So if you are, particularly if you are changing the specifications, or you're changing the metrics against which the contract is based on. So a lot of the NHS contract for services is very didactic in terms of it's very set, whereas there are small elements of it which can be negotiated, and that kind of a lot of that stuff happens before the full operational planning, the national operational planning guidance comes out. I don't think there'll be major changes this year, because the last year's payment system was designed for 2 years, so there might be some small tweaks, but I'm not expecting, famous last words, not expecting any dramatic changes, because they established it for clarity that it was going to be for two years. So this year, the current year, and then the following year, that's what the payment system is going to stay the same. So hopefully, if you are expecting a increase in your activity or decrease in your activity, and you want to change, or your costs don't seem to add up, then you really need to get stuff in now. And contact your finance teams or your contract negotiation teams now, so that they can make the changes necessary before the contracts get agreed in kind of January, February time. Hope that makes sense. Becky, are we?
Yeah, Mark's here now.
Okay. I'll try and work out what left shift means in terms of what context in a bit, and come back to you after Mark, and maybe one of the latest speakers might be able to explain that, because I missed bits of Anthony's talk, so I'm not entirely sure what it means. Okay, let's. I'll try and address those in a bit. I'll get Mark, who's the learning development lead at the Healthcare Supplies Association, to come and do his talk, and then we'll try and catch us up before lunch. Over to you, Mark. Thank you very much for joining us.
Thank you. Good morning, everybody, and welcome to my kind of little session. I think most of this seems to work by answering questions, so I'll kind of run through my my slide presentation, but please feel free to kind of stop me at any stage, or put your hand up, or whatever, to kind of grab my attention. Introduction to procurement. At the moment, we're going through a massive change. There's new legislation which got royal assent a couple of weeks ago, and it kind of gives an overview of the future in the way that we're going to handle. But really, procurement still comes down to a number of basic issues. And the basic issues are about the 5 rights of procurement: quality, price, quantity, place, and time. It's a very, very simple mechanism. If you want top quality, you'll probably have to pay top price. So what we're looking at here is that we have to do a lot of trade-offs between some of these. If somebody comes to me and said, "Will you just place me an order for this?" and I'll say, "Well, what about some competition?" "Oh no, we can only get it from this place." If one of the great tools that we now have is Google, and you just type into Google something, and it gives you a number of kind of suppliers. What I need from you guys is help. I don't know the kind of stuff that you buy. I mean, I've got a good idea on certain things. If it's a tin of beans, it's a tin of beans. However, if it's a very intricate piece of medical equipment, then I need helping and guiding by you. But I also need you to give me an opportunity to look at the commercial aspects of it. And as I say, we kind of trade these things off. The more that we buy, generally the unit price is cheaper. We always tend to want to underestimate how many we buy, but that doesn't give us the best opportunity. So we're starting to look at kind of some of the basics, and sorry if some of you are more well versed in procurement, But whenever I teach or train procurement people, this is a simple thing that I go back to. If we get these right and we understand markets, there is actually an extra argument to say, well, should there be a sixth right in getting the right supplier? The right suppliers are obviously key. So what we need to start doing is developing is a three-way discussion between procurement, the end user and the supplier to find out actually what's in the marketplace. Because if you ring a supplier up, they'll wax lyrical about their products, but you also need to understand about other people's products or services. It's easier to deal in products because it's a physical thing. Services are normally far more complicated in terms of looking at, you're dealing with people, and people can vary so much in what they deliver. If that person changes, if you get somebody new, then it's building up a new relationship. It's all about engaging with stakeholders. So, definition of a supply chain, and we learned very much in a hard way over the last few years with COVID about not understanding the supply chain thoroughly enough. We tend to deal with suppliers. And in this country, we're very fortunate that most of the big brands, the Johnson & Johnsons, the Smith & Nephews, etc., are based in this country or have major supply chain routes within this country. However, they weren't always able to satisfy the needs that we had because it was a crazy time. And full respect to you guys for actually being able to deliver the patient care that you did over these last few years. But what we need to look at is we need to understand the complete supply chain, because we were having to deal with people in China that we'd probably never dealt with before, and building relationships up in certain countries actually takes quite a long time. And a lot of the sourcing of products was down to who had the cash available. So there'd be containers on docks. And these are all part of the procurement function in making sure that when you go to a particular place and put your hand into a cupboard, you expect whatever it is to be there: needle, syringe, bandage, heart valve, pacemaker. So what we need to look at is the activities required by the organisation to deliver goods or services to the customer. And in most instances, obviously the end user is yourselves, whether you're putting it into a patient or using it to improve the health of a patient. So we have, please bring us in as early as you can in any procurement that you're going to look at, because we can help and we can guide. We are going to be through a learning process over the next probably 12 to 18 months with the new regulations that we have. At the moment, they will be starting training courses on this for procurement people to actually understand the rules. Because when you get a new set of legislation, that it's all about interpretation, and it's only when these things start going to court do you actually get a true interpretation. So we're governed by a lot of things. Standing financial instructions, standing orders, which you're all probably aware of. They're the rules that we have to work to. The Public Contracts Act, contract regulation is now changing. That was to do with EU procurement. We're obviously out of the EU, and this new procurement law that's hitting us will come more prevalent. There's also other acts that we have to take account of. So, for example, some of you may remember some years ago we had ward budgets for making the ward a bit more of a pleasant place, and we were finding that people buying stuff from Marks and Spencer's, and we said, have you got all the fire regulations in place? Oh no, it just looked nice, and they started to bring things onto wards that actually were quite dangerous. So we're there to try and help and guide. Procurement is there, it's a support service to you. It's not there to say no, you can't have. It's to help and guide and make perhaps suggestions in the way that we deal with, certainly with suppliers, because suppliers are very they'll try and get to you before they get to us. and influence you, and to say that this is the only thing that will kind of work. And it's a very difficult situation, because at the end of the day, you're there saving patients' lives, not me, and you need to make sure you have appropriate kit in that arena. And as I say, you're the specialist. We'll ask you maybe for a specification, but we also need to ask you how we're going to evaluate that specification, because unless we can evaluate it, how do we know it's actually the best piece of kit? And we're going to have, over the next few years, a great deal of underfunding. We're already in that position. So the directors of finance, I think, will be starting to look at where savings can be made. We can help you with that. Just come and ask us. So we start to look at value is outcome over cost. It's like the word of quality. What is value? There's a lot of situations now where value-based procurement is being looked at, but we do still work in these silos of years. Some people will look and say, right, okay, provided we get a return over a 3-year period, then that's okay. But we're also starting to look at scan for safety, what products should be used and what services should be used, based against cost. And unfortunately, we've been in an inflationary position probably for the last 2 or 3 years, and costs are just going up and up and up. You can tell, you know, when you're at home, your energy bill's going up, your food bill's going up, and obviously suppliers want to pass those costs on to us. And what we try and do is negate those increases. Inevitably, the prices will have to go up. So where we're looking for cost savings, we're going to have to be a bit more imaginative, perhaps, in the way that we deal in things and the way that we deal with suppliers. We can talk to suppliers, and they quite often come up with quite innovative either products or services. Normally they're at a higher price, but we may need to look at the way that we actually continue our working practices. Do we change them? Do we not change them? And all that is based on what's the best outcome for that patient. So the kind of way that we operate and think about things is looking at, and again, it's about proportionality. It's about the value of what you're dealing in. If it's a multi-million-pound thing, that's one thing. If it's, you know, a tin of beans, then that's a totally different thing. But we start to look at the planning, the procurement, and the implementing. And it's the implementation stage that we can probably actually make more headway with in implementing things in an orderly and sensible fashion, in the terms that quite often we will buy something, and I mean, we're coming up to the infamous year end. How much spend there'll be, I'm not quite sure, but traditionally we've bought machines and I've seen them on the corridors 6 months later. I think those kind of days are subsiding, but we need to look at, when we've gone through a procurement, what we've learned from that. What have we done right? What have we done wrong? Because we continually change, and we continually change our working practices in order to ensure that patients get a better deal out of it and recover better, because people only tend to come into hospital when there's something wrong. So it's always a difficult position to be in. So I've kind of tried to look at the procurement cycle. I think again, I'd still like to go back to these five rights of procurement. And before you purchase anything or set off down a path, is to make sure that what we're looking at is a balance between those 5. So has anybody got any questions? They're all very quiet out there. Somebody's got their hand up. Sandra at the Royal Wolverhampton, you've got a question?
Hand up, sorry. I don't know whether it was a wrong hand. No, sorry.
Right, okay. Or Sean Beckwith.
Sorry, I didn't realise I had my hand up.
No.
You've got some in the chat.
Oh, right. Yeah, please.
How does financial information help inform procurement decisions?
How does financial information? Right. I suppose it it very much depends. First of all, you've got to look at the budget that you've got. And if we have that information, a lot of the product ranges and services that we now have are benchmarked. There's a national benchmarking tool. So if we start to look at that, and quite often the price that you pay for something is more to do with the relationship that you have with that supplier. So it's great being armed with the financial information. However, you also need to consider where you sit in the marketplace. Because I've seen on these benchmarking tools, which every trust should have, people buying many products actually paying a higher price than people buying smaller numbers. And that's to do with the relationship. So it's about understanding the marketplace. It's about understanding what your budget is. So yes, it will inform, but also we start to go back to the 5 rights in saying, well, is that price the right price? If it isn't, why isn't it? And do we need to have a better relationship? Because sometimes suppliers will come in and try and undercut your existing suppliers just to get a foothold within your trust. Okay, what's the next one, Becky?
Jessica says, possibly a silly question. What do you mean by place?
Place, right, okay. No, there's never a silly question. If you don't understand, then please stick your hand up. It's something I learned very early on in my career. It's where the product or service will be delivered. Now, some of you will just have one building as part of a trust, or if it's a community base, there may be many buildings. So we need to make sure I've dealt with a lot of areas, and suppliers are great delivering to a major university teaching hospital in one city. However, and I always pick them out a little bit, that somewhere like Great Yarmouth, who have a smaller hospital, are a bit of a nuisance customer because they're in the middle of nowhere. So whereas with a major trust, you're probably making a big delivery, you may not be making a big delivery to somewhere like Great Yarmouth. So you've got to understand the cost of service to that particular thing. So it is about the physical site of where you are, in answer to your question. Any more?
Next question, where does ethical considerations and social values / anchor institution thinking fit in?
Is that one question or many? Okay, it's all part of about dealing with your supplier. It's all about the supply chain. Is it an ethical issue? So obviously we've had examples of the wristbands that Oxfam made were being made by enforced labour. So we need to start to look at every supplier that we deal with. First of all, has to have a statement around their policy about modern slavery. We also need to make sure that we understand the supply chain, and I take it back to another slide that I did. So the activities required by the organisation deliver goods or services to the customer, and what we need to understand is our supplier may not be the manufacturer of that. So we need to start going backwards along the supply chain to looking at where the raw materials are sourced, where the initial manufacture may be done, or the processing of the raw materials that are manufactured over here. So we need to understand that they are coming from reputable suppliers. We also need to make sure that there is value within our locality for using that source of supply. Okay.
Hazel has built on that question and says, and also environmental impact given our aspirations towards net zero.
Yeah, it's a difficult one. I mean, we're at the moment, there's an outcry in Parliament, isn't there, about issuing more licenses for oil and gas exploration in the North Sea. We can start to look at things like getting suppliers to use electric vehicles, the impact on the environment, reducing carbon footprint. Those, however, let's not forget, may come at a cost, and that's something that we need to balance off. So if everybody switched to electric cars tomorrow, would we have enough charging points for all the cars, or would we actually have enough energy for all the cars? So it's a dilemma. We understand that. I mean, the government have put back the removal of diesel cars off the road for a period of time. But these are all considerations that we need to deal with when we are looking at suppliers and looking at the products that perhaps we use. Okay. Any more, Becky?
How much flexibility is there when it comes to supplies and where products can be purchased?
That's a good question. It depends what you want to do. There are many routes in that we have to ensure that, first of all, they are a compatible supplier that we would be working with, bearing in mind the questions that have been raised about social value, about environmental friendly, etc., etc. It's really up to the end users to where they want to buy things from. However, if they're wanting to buy products from another, rather than the traditional maybe NHS supply chain route or off a framework, they'll have to look at what the implications of that are, because it may well be cheaper to buy direct, but then there's all the on cost towards that. So I think that the thing is, sit down with your procurement guys and say, look, we don't think this product or service is suitable for our needs, or what can we do about it? So again, it's about having that dialogue with your procurement people. We're not here just to say, no, you can't have, no, you can't have. That's not in our interest whatsoever, because we're a service to you. So the point is that sit down, explain why you want something different, and let's sit down and talk about it, and what can we facilitate. Is there any more, Becky?
Yeah, a couple more just come in.
Yeah.
The agenda for your talk mentions category towers and frameworks. Can you explain these?
Right, category towers and frameworks. Framework is a deal that has normally been struck with a number of suppliers that have gone through a process. Sometimes it's a single source supplier, but other times a framework will allow a number of suppliers to bid for whatever work it is that you want. And there's normally a second stage where you put a requirement into them and say, right, what deals can we do? A category tower, of which most of those are now in-house, there's only one or two that are external to NHS supply chain, are specialised in certain areas, so cardiology, renal. And what they will do is they will look at the market globally and see what are the best deals available, and probably again put those on a framework. But whereas when I was a director of procurement at a trust, I was probably a jack of all trades, master of none. Whereas these people tend to specialise in specific areas. So that's what a category tower is. Okay.
John says, what is the framework and what if the company is not on it?
Well, I don't quite understand what you mean by the framework. The framework is normally a list of suppliers that can offer either a list of goods or services. If they're not on it, there may be a good reason for it. They may not have met the criteria that was set out in the original invitation to tender. So they might have failed on certain things, or they might not want to bid for that work. It could be as simple as that. You know, suppliers have a choice. They're not forced to enter onto frameworks, but normally people want to maintain their kind of market share, and they will put their offers in, and we quite often it's NHS supply chain will put those offers available to you, and you may use whichever framework supplier you want off that framework. I hope that that clears frameworks. Any more?
Amelia says, do most or all trusts have outsourced procurement support?
Depends what you mean by outsourced, because some procurement organisations actually sit outside the trust under a separate body. So, for example, City of Sunderland have an organisation called Choice. They transferred out their procurement staff into this standalone body. There was a bit of a push for it because there are some VAT benefits by outsourcing it. But I think most trusts either have in-house, or it might well be under the new ICS regime, there might be a higher tier. So for some of you who've been around a while, we used to have local, regional, and then the Strategic Health Authority. We're kind of going back to that. Everything was then pushed down to trust when competition was brought in, and now we're kind of going back to more of a regional under the ICS organisations. Okay.
Last question, can you request a supplier is added to a framework?
Depends on the framework. Normally the framework will run for 4 years. It can be extended under certain circumstances, but there is something called a dynamic purchasing system, which is basically a framework, and people can be added onto there, and as people can also be taken off. Not all frameworks are on a dynamic purchasing system. You would have to check with whoever let the original framework as to whether that there is or not. But normally speaking, under a framework, no, you can't add people on unless it's a dynamic purchasing system. Okay.
No more questions, I don't think.
Oh. Well, I mean, again, thanks for kind of listening. I hope I've given you an overview of procurement. As I say, if you keep going back to these before you ask procurement or in a discussion with procurement, just think about the 5 rights: quality, price, quantity, time and place. And they will help and support you in understanding the marketplace that you want to buy goods or services in. And their function is to try and facilitate getting the best deal for you. But other than that, thanks for listening. If there are any more questions, then please send them to Becky, who will forward them on to me, and I will answer them to the best of my ability. Thank you very much.
Thank you very much, Mark. Thanks for coming along. As always, he's very often comes and joins us and helps us out on these days. So thank you very much. I would say that there are a couple of things in terms of there's procurement for goods and there's procurement for services when you're kind of things like commissioning, and the underlying principles are the same, but the process is slightly can be different. And what you'll find sometimes is that for smaller suppliers or smaller providers of services, the paperwork involved in getting onto a framework agreement, particularly the national ones, are quite onerous. And so that's one of the reasons why some of the suppliers don't want to or cannot fulfill the criteria, because they're too small, because the paperwork is such a large kind of just they can't go through it, essentially.
Yeah,
it's too expensive for them to go through it.
I suppose it is difficult for SMEs to get onto frameworks, and that's something that the new regulations is looking at trying to help and support to make it less onerous. But we also have to balance that against making sure that they are a fit supplier to support the NHS in terms of social value, because some of the smaller companies find it rather difficult to do everything that the NHS wants, and I don't think that's an easy question to kind of answer. But all we can do is talk these things through, look at the legislation, and try and wade through it, and try and make sure that the smaller suppliers do get a fair crack at the whip.
Great, thank you very much. And there is actually a hand up, so just in case there's a quick question from Emma. Emma Johnson.
It's an error. I pressed it by accident and I couldn't get it back down.
Okay, no worries. No problem at all.
Thank you.
That's fine.
So as I say, if there's any more questions, then send them to Becky and she can forward them on to me, no problem.
Great, thank you. Now, is our next speaker here, Becky? Before otherwise I'll Phil.
Yeah, they are. Yeah.
Great. So next we normally have a little bit of a case study next, where we ask an ICB to come and explain their journey to an integrated care system. So I'd like to invite Opinyemi Aditon Kunbu Aina, and I apologise if I've said that wrong. My name is particularly difficult to say, and I've been practicing, but I'm not sure whether I got it right or wrong. Who's Associate Director of Finance at NHS South East London ICB.
Thank you very much, Akiban. Very good attempt at pronouncing my name. Well introduced. Thank you. So I'll just progress on. So, Becky, would you be sharing the slide, or how does it work?
I can share them for you if you like, or you can share them, whichever's easiest.
Yeah, you can share them. I will appreciate that, please.
Oh, let me just get them open.
Thank you.
I've only got them as a PDF, so I won't be able to share them as a PowerPoint. Is that okay with you?
Yeah, that's fine.
Yeah, cool.
Thank you. Today we'll talk about the journey to an integrated care system. We'll look at the previous legislative reforms, how we moved on to integration, how that emerged, and the development of the ICS across South East London and what it all means in its partnership. So if you move on to the next slide, please. Yeah, the next one, please. So it feels like we wouldn't do justice to this journey without understanding major previous legislative reforms that have occurred within the NHS. The key one is the NHS and the Health and Social Care Act of 2012, and seeing what exactly happened, what was the structure before then. And it'll be interesting to look at the pre-April 2013 structure of the NHS. From the UK Parliament, we had the Department of Health, commissioning service to the Strategic Health Authority, and then monitor who were regulators of Foundation Trust and the Care Quality Commission licensing and inspection role. And from the Strategic Health Authority, you had the Primary Care Trust, commissioning primary care services to the NHS Trust, NHS Foundation Trust, and other providers. Then we had the enactment of the 2012 Act, which was considered controversial, but it was a major reform at that time since NHS was formed in 1948. One of the key things that it did was NHS England and the clinical commissioning groups called CCG then, they took on statutory responsibility to commission health services. And then local authorities then had new public health responsibilities. And then we had the local Earth Watch organization that came into being that advised the CCG on the needs of the people within a particular area. And this Big Bang Act of 2012 abolished the Strategic Health Authority and Primary Care Trust. But what it created was a competition market. It made the NHS internal market competitive, especially around procurement and services, such that it was services available to any willing provider, whether private sector or social enterprise. And CCG would assess the needs of what its local population needs and then bought those needs within the budget available to them. Next slide, please. Thank you. Then we have the move to integration. How did we get to where we are? When did integration started? So despite the major reform of the Act of 2012, NHS continued to face demands and costs, and there was a widening gap in the health of the population and quality of care. In fact, it was the projected gap was thought to be unacceptable, unprecedented, and it threatened the stability and sustainability of NHS as a whole. To close this gap, the government mandated NHS to come up with a plan. The plan then was what we call the five-year forward view, which was published October 2014. The ambition was for greater partnership and propose new ways of collective vision for how the health system was going to change from 2015-16 to 2020-21. And this was a move towards collaboration. There were three key drivers for this change. One is health and well-being. The second was care and quality, and funding and efficiency. On 16th of December 2015, the Sustainability and Transformation Fund, STF, was released for 2.1 billion. The intention was 1.8 of these was to provide help to challenging hospitals to achieve financial balance. Now, the central focal point of the five-year forward view was to accelerate integration because it became obvious that competition was not going to work. So we'd rather have integration of health and social care services. At this point, NHS organizations were asked to come together to create this blueprint of how they deliver the five-year forward view. And this evolved into what we call Sustainability and Transformation Partnerships, STP, evolving from place-based approach to health, which means location of where you are, approach to health. And by end of January 2016, local health, local NHS services and local authorities, they formed 44 separate STPs. They were made up of the CCGs, NHS Trust, Foundation Trust, including mental health and community, and primary care services. And then you had local authority also involved and other health and care services. The STP were required to integrate better, but there was barrier still to this because you had the statutory legislation, which still meant there was competitive arrangements among these STPs. If you move on to the next slide, please. Now, we're getting closer here to what we have as the integrated care system, and it's important to define this. So, integrated care system, short name ICS, they are partnerships that bring providers and commissioners of NHS services across a geographical area, and that's why we say place-based. Bring them together with local authority and other local partners to collectively plan health and care services to meet the needs of their local population. What this is doing is solidifying that move from the old legislative focus of competition to that of collaboration. And from what you've said, you will realize that ICS existed in one form or the other since that 2016, since that time of STP. So the point was, if it was an well-established STP, if it's well-established STP, you had like an ICS already forming at that point. Now, but the issue was they operated as informal partnerships. They used soft powers and influence to achieve their objectives. And they took planning and commissioning care for the population in which they serve. Now, at this point, the Conservative government mandated NHS again to come up with a plan, a 10-year plan, to continue to close that gap for health, that health inequality gap within the system. And NHS England produced a 10-year plan that we call the NHS Long-Term Plan, NHS LTP. And it was to improve access to care and outcome for patients. And significantly, it then proposed the legislative change to the system architecture of NHS, bringing together different NHS organizations and local into ICS. And the much needed legal framework was achieved when the Health and Care Act 2022 received the royal assent in April 2022. This was the biggest form, considered the biggest form of reform to NHS in a decade. Now, at this time, there are now 42 ICS across England. They cover within population of 500 to 3 million because, of course, geographical area and population will differ. This is a drive towards, statutory legislative drive towards collaboration. But the point is, it will require change in behavior and attitude across the system. If you move on to the next slide, please. So from the viewpoint of NHS South East London, how did we emerge? NHS South East London was our healthier South East London, which was one of the capital's first STPs. It was a formation of 6 CCGs, local authorities, 5 providers, provider trusts, and numerous voluntary sector partners. And you will see the map there of the 6 CCGs and local authorities. And by April 2020, we had moved to form ICS by merging those 6 CCGs together. And then we became that integrated care system across health and social care services. 1st of July 2022, with 1.9 million population, we were established as a statutory body to support and build upon that existing ICS system we already had, and what we've had from a very strong STP, our Healthier South East London. If you move on to the next slide, please. Now, with that 2022 Act giving ICS that statutory status, all established in the country, we now have what are the key aims of an ICS. One is to improve outcomes in population health and healthcare. We want to enhance productivity and value for money. We want to tackle health inequalities and outcome experience and access to health, and then support broader social and economic development. The Integrated Care Board has specific membership, which I will talk more detail again in the next slide. Then we also have the Integrated Care Partnership between the ICB and ICP. Is a cross-body membership that influence and align together. Then we have partnership and delivery structures that work along this kind of integrated system. We have the provider collaborative, health and wellbeing boards, place-based partnerships, and primary care networks. So if you move on to the next slide, we'll see this more in details. Now, let's look at the Integrated Care Board itself. So the main role is to deliver the integrated care strategy, to develop a plan to meet health needs of the population, directly accountable to NHSE for the NHS spend and performance within the system, and then arranging for the provision of this strategy of health services in the population. Membership peculiar. There are a bit of variance across the country, but peculiar to SEL, which is Southeast London ICB. We've got the chair, chief executive officer. We have 3 non-executive directors, executive director of planning, chief of staff, the chief finance officer, chief nursing officer. We have 2 joint medical directors, director of communication and engagement, chief people officer, place executive directors. We have 6 of them that represent the places that cover this geographical area I spoke about in the earlier slide. And we have partner members that represent the primary care sector, mental health, community service, acute care, and local government. And just to note that the money still flows from Department of Health, and you can see there how it flowed in 2023 spend. For us as an ICB, we have 6 priorities. We want to prevent illness and helping people to live healthier and happier lives. We want to ensure rapid access to high quality specialist services when people need them. We want to improve care for disadvantaged groups. We want to deliver compassionate all-person care as close as possible to people's home, joining up care across health and other services, supporting the development of more resilient communities. If you please move on to the next slide. Now, what structure, for SEL, ICS, the structure very similar to what has been statutorily provided. And just to say, we have that integrated care partnership. What does it do? Because you wonder, you have the integrated care board and then you have partnership. So the partnership sets strategic direction and lead some key programs and help to hold system to account. So that's why we said they co-check each other. Then we have the board, which has that sole responsibility of strategic planning, use of NHS resources, and overall performance. We have the local care partnerships, very important because they lead integration and innovation in community-based services in boroughs place, very important for the place, and neighborhoods, which aim to build community as well as joined up care. Then we have the provider collaborative. We'll see this in detail, how it works in Southeast London ICB. We have these are a group of providers. They are leading improvement of specific services. It could be provider on the acute, mental health, all across Southeast London, including planning, quality improvement, use of resources, and benchmarking. Then we have the primary care network. These are GP practices working together with community, mental health, social care, pharmacy, hospital, voluntary, community, and social enterprise services in local areas. So these are really localized, place-based services. If you move on to the next slide, please. Now, you would see the diagram of how we see our ICP, how it all joins up in there without repeating it. Now, we've said it's a joint committee of the ICB and local authority. That's how it's represented in Southeast London ICS. And it brings together the broad set of system partners to support partnership working and develop an integrated care strategy to address the wider healthcare, public health, and social care needs within our population. So the set strategic direction of where we're going and the leadership for that. So members of our partner includes our 6 local authorities, the chairs of our biggest provider organization, director of public health, adult social care, and children's services. We have representatives from the King's Health Partnership, primary care and voluntary community, and social enterprise sector, and Health Watch. If you move on to the next slide, please. Now, our provider collaborative, just so you see how that works within us. So as we define what they are, so we have 3 of them. We have the Southeast London Acute Provider Collaborative, also called APC. The members are King's College Hospital NHS Foundation Trust. We have Guy's and St. Thomas NHS Foundation Trust, and we have Louis Sherman and Greenwich NHS Trust. So they work together to improve the way acute care, for example, refer to short-term treatment, works and is delivered within Southeast London. Now, the core component of this collaborative work is elective, which is care that is planned in advance, and diagnosis which tests, which helps to eliminate the nature of a disorder or illness. So now our APC reports into the committee in common of the 3 trust board and to the ICS leadership, recognizing that collaborative key part of our Southeast London. Then we have the SLP, which is South London Partnership Mental Health Services. It comprises of Oxley's NHS Foundation Trust, South London and Maudsley NHS Foundation Trust, and South West London and St. George's NHS Foundation Trust. You can see that this is a bit different. This is more South London. So here we've crossed path into Southwest. Now, it collectively delivers mental health services to a population of about 3.6 million across South London. And we work across the 2 ICS and the boroughs partnership to do so. This is because, you know, this is how it will benefit the people, the population better. It takes delegated responsibility for NHS England on the commissioned specialized services and for CCG funded complex care. Then we have the CPN, which is South East London Community Services Provider Network. This has Guy's and St. Thomas FT, Bromley Health Care CIS there, and Oxley NHS and Lewisham and Greenwich Trust. The CPN comprises of all South London physical health community providers and is an informal network rather than a formal collaborative, and is focused on working together to define and implement common standards and core community offer for South East London residents. So all this partnership make sure that no parts falls through the nets. If you move on to the next slide, which I think is the last one. Now, important to also know that about the local care partnerships, LPC, and this includes the primary care partnership really. So these are GP, the primary care partnerships, they are GP practices that work together with community, mental health, social care, pharmacy, hospital, voluntary, and voluntary community and social enterprise services in the local area. And they are part of the LCP. Our local care partnership, we bring together NHS, the local authority, voluntary, community, and social enterprise organization from across our health and care system. The plan coordinates services more effectively. Every local care partnership deliver a more integrated care because it's closer to the people and well-based system for the population. And we have 6 of them that aligns with the 6 place that I've introduced. So let's look at Bexley. We want to transform care. So these are the key values and mission of each of them, and it will be important to look at them. We've got the Bexley's vision is to transform health and care services through local care network with partners from across health and care system. We have the Lambeth, we have One Bromley, Lewisham Health and Care Partnership, Sodok, and Elvia Greenwich Partnerships. So I think this brings us to the end of our journey to ICS and the components. Thank you. I'm happy to take any questions. Or is everybody thinking lunch already? See if there's anything in the chat.
Doesn't look like there's any so far.
Any views?
Oh, we've got a hand up for
Right.
Julie.
Okay, yeah, right.
Hiya. Thank you very
Julie.
much. That was really helpful. I've got a question. My background's commercial, so I deal with the procurement and contracting side within our ICB. And what I'm struggling with is as we start delegating, or not delegating, as we start behaving differently in the way we collaborate with our other NHS Trust colleagues, and things like the voluntary sector and the independent sector, the conversations that are happening now in things like these CPNs, etc. How do we make sure that we still control the way we commission our services? What I'm starting to see is that conversations happen within these groups that then translate into a new commissioning arrangement or could translate into a new commissioning arrangement if we're not careful and we haven't got eyes all over them. I'm trying to keep us safe under the Procurement Act, as it stands currently, which is still the current rules, and moving into the new procurement provider selection regime, I'm really keen to make sure that we keep the way we carry on commissioning services safe, being mindful that conversations aren't just happening within our ICB now, they're now starting to happen across the whole healthcare system. I'd be really interested to know if you've managed to solve that one.
Yeah, well, solve experience on that, yes. Solve, I think, is a work in progress. So experience in Southeast London is we've had that happening. For example, discussion happening in the APC, Acute Provider Collaborative, on some things, and it's not come through the ICB governance. The thing is, it just before it gets to the point of it being commissioned, it needs to go through the proper governance process. So it's about setting up that governance and then communicating it to people, communicating it down the line. Governance around, you mentioned procurement, we've seen it in capital, we've seen it in expenditure area, and I'm sure other colleagues in other parts of clinical area will be seeing things happening. It's just ensuring that the governance, if a paper needs to be published, it needs to be on your intranet. It needs to have been approved. It needs to be updated, and needs to be constantly communicated and cascaded down. And then when you are having meetings, when people start having meetings, for example, in the LPC that we mentioned, there should be representation, for example, from procurement, whatever, and if you haven't heard about it, you being the procurement lead, then somebody there should say, actually, my procurement lead needs to know about this. And that's how we keep that. And of course, finance keeps a lead. Before anything is signed, they make sure, has it gone through that? We just have to ensure that. Right. Thank you, Julie. That was a good question.
Thank you. It's really helpful. Thank you.
Yeah, that's all right. I think there are questions in the...
There's some in the chat. Do you want me to read them out for you?
Yes, please.
Yeah. Emma says, how does the Tier 3 weight management programme fit into these different groups?
Right. How does the Tier 3 weight management programme fit into this? Or I think I would have to respond back into that, because I like to give a more robust response on that. So if we take that away, I'll take that away, and I'll send it to you, Becky.
Yeah, that's cool. Louise says, regarding your last slide, would there be a plan to integrate services like that?
So like the LCP, local care partnership, they're already part of the, I think, can we have more clarity on what do they mean?
Yeah, sorry, I was just thinking, you had lots of different areas saying more or less the same thing about what they wanted for their local population. So are they likely to stay separate or continue to operate those sort of all those separate things within the ICS?
Right. Oh, I see what you mean. The local care partnerships.
Yeah.
Is that what?
Yeah.
Oh, I see what you mean. Right. So they are not separate. These are the place. They call the place-based partnership. So this is about bringing the central strategic drive down to place. So it looks like and that's why I didn't bother to say everything, because everything will be about improving care. The ICB aim itself cascaded down to place. Put it simply. So they just place this. We are already integrated. We are one organization. We're Southeast London ICS, but this is the beauty of the ICS days, where you now have the place-based representation, and it's just cascading down that vision. Describing.
I see. I thought it was the other way around. They were things that already existed, and they were feeding in. Okay, that's fine. Thank you.
Yeah. All right. Yeah. I think there's a question here. Is it from HD? Ellen?
I think it's more of a comment. They say they work for an ICB serving a smaller population with 2 LAs, and thought it was an interesting presentation. I think that's it for questions now. If anyone has any more, just pop them in the chat. But if not, then it is now time for lunch. And AK will be back at 1:10 to answer any questions that anybody might have for him, but if not, we'll see everyone at 1:50. Thank you for coming today, RPMA, as well.
All right. Thank you all.
Hello, everyone. I'm not sure if everybody's back from lunch yet or not. I've jumped on a little earlier to see if I can answer any of the questions that I missed earlier on in the session. Before you get to listen to a fascinating talk by a good friend of mine. So if you have any questions that haven't been answered, because I know that there were some questions earlier on that I missed out, and I'm not sure if they were answered in subsequent talks. So I had to jump off the meeting to go to do something else. If you can repost them, I will try and answer them either now or between the next session. Knowing Gareth like I do, it's unlikely he'll finish early and more likely he'll run over. But if there is time, I will try.
I will do my very best for you, AK.
Different topic though, Gareth, so you never know. Yeah,
there's more data to talk about in this one, so I'll talk for even longer.
Oh, great.
I promise I will do my best to keep to time, and you can kick me out if I don't.
No, it's fine. No, it's always a great talk, so I wouldn't want to deprive anybody of your
verbosity.
Yeah, succinct isn't the word I'd use.
I wouldn't use the word succinct. I'd probably use another 4 words to make up for it.
Try to scan through some of the questions from earlier. I know some talk about business cases, and I think I'll try and address some of those things later on about putting together data for putting together an business case and how different business cases can interlink. There was something about left shift, which I think is very specific to Leeds, and it's about addressing health inequalities. And it's about identifying people earlier on, so that in their disease process, so that you actually save money because there's an increasing wealth of knowledge that suggests that people from different, both socioeconomically and ethnically different parts of the country have that inequality, that those people who present later on often have higher complications and worse outcomes. So there's a lot of work to try and identify those people and catch them and get them, engage them with the health services earlier on. We have a couple of dates in the diary, haven't we, Becky? We've got the 24th of January for the next one, and there you go, 13th of March,
just sticking my nose in at this point in time, where what AK is talking about there in terms of those health inequalities, PLIX data, which I'll be talking about, is absolutely something that can be utilised to demonstrate that a later presentation is not only worse for the patient, but it's worse for the public purse as well. So when you are pulling business cases together, demonstrating cost avoidance is always more difficult than demonstrating income generation, but PLIX data can help you to try and articulate that case for the cost avoidance.
So either people haven't joined back in yet and they're still eating a lunch, or there's all the questions have been answered. I will hang around. I'm staying logged in until I have to briefly leave for a bit at 3:30, but other than that, I'll be around for the rest of the session, and we'll be joining again for my business cases talk at 4. For those of you who can last and have the stamina to get through the whole day and get to the end of the session.
Are you sure you don't mean who have the stamina to actually listen to me talking, AK? I know what you're really saying there.
I didn't say anything. So I'll give it another minute for people to join before we get you going.
I'm just going to start launching my PowerPoint live because it takes a minute or so to initiate. So I'm just about to do that, if that's okay.
Okay, so as it's 1:15 on the dot, and I want to keep to time as best as we can today, so we can finish on time. I've got Gareth Jones, who's Costing Development Manager at Manchester University NHS Foundation Trust, who's going to be talking about costing and PLICs in the acute system. Now, I've heard Gareth talk numerous times about coding. His background is a coder, and I'm stealing his thunder a little bit now. But he's an excellent speaker, and will give you a very good and informative and entertaining rundown of how you can use PLICs and costing to improve value. Over to you, Gareth.
Well, thank you very much for that introduction, AK. I've got a lot to live up to, given that I'm going to be largely talking about accountancy processes to some degree. So it's a bit of a tall order to make that interesting and informative and fun, but I'll do my very best for you. But for me, I'm more than happy for you to ask questions throughout the session. But I don't know how the rest of the session has been run to this point, so I'll let the organisers do that. Just to say, Becky, it looks as though the recording has stopped according to what's on my screen, so I don't know if that's intentional or whether you're intending to restart the recording.
I think when it gets to a certain amount of time, it like stops and then starts again, because in the top left
Okay.
it still says it's recording, so hopefully it's...
No problem. I will not waste any further time. Okay, so as AK says, I'm Gareth Jones. I'm Costing Development Manager at Manchester University Foundation Trust, or MFT, for the purposes of getting through this quicker. What I'm going to present to you today is an overview of how costing is done in the NHS, how that leads into PLICs, which is patient level information and costing systems, a specific approach to doing NHS costing. And I promise there'll only be a tiny little bit of it that is very specific to MFT. So I will dive straight into it. So what is costing? Cost is the money spent to deliver a service. It measures resource that is used to treat a patient. Resources could be nurses or doctors, it could be consumables, any devices, it could be estate costs, it could be any number of different costs that are accrued in treating a patient. And we measure activities, and those activities could be inpatient admissions, it could be specific surgical procedures, it could be the amount of pathology tests there are, the amount of outpatient clinics that there are, could be any number of different touch points in which a patient comes into contact with healthcare. The costing process then links that cost to the activity. So at this point in time, I've only given you one slide's worth of context, but I'm going to challenge you on this next slide to try and tell me how you think that some of the apportionment or cost allocation methodologies might work for certain types of cost. So what we've got is there are a number of patient-facing costs, which are fairly self-evident, things like ward costs, theatre costs, radiology costs, pathology costs, and drug costs. But there are non-patient facing costs, and things of that nature could be estate costs, which would take into account, say, the amount of floor area that is taken to actually treat a patient. It could be corporate services such as HR or IT. In the instance of MFT, we utilise the number of whole-time equivalents, for example, that those HR and IT and those corporate services will be servicing, and that is how we dissolve and disaggregate the amount of cost that those corporate overheads should then feed into the patient care. And then finance overheads. So we do it by virtue of the number of cost centres that there are. The number of cost centres tends to drive the amount of finance people that you need to drive your services. So when we identify those costs from the finance general ledger, we have to transfer those non-patient facing costs into being patient facing costs. So rather than ask you right away for every single different allocation methodology, I'll give you a little bit of a leg up in telling you how we do ward costs. So we look at the number of minutes that a patient is on a ward. So we look at admitted patient care data there that tells us at what point they entered onto a ward and at what point they were discharged from that particular ward, or if it is a spell of care where they've had multiple transfers, we will look at the care across that entire spell of care. The costs, however, are allocated at an episode by episode basis, so each one of those transfers will be calculated in of itself. So the calculation methodology there is the number of minutes that a patient is on the ward times the acuity of their care. That acuity is measured by something called a HRG. A HRG is a healthcare resource group, and I know a colleague of mine, former coding colleague of mine, Sam Levy, will be doing a presentation on clinical coding in about an hour or so that will go into further detail about HRGs. But in essence, what they do is describe the level of complexity that a patient has got. So we times the number of minutes on the ward by the level of acuity that they have, their treatment has undertaken, has cost. Is anybody feeling brave about venturing a guess as to how theatre costs might be calculated? Karen Connolly from Blackpool Teaching has jumped straight in. Number of patients times number of skin, knife to skin time. So almost exactly right there. So what we've got is it's the number of minutes that the patient has been in the theatre, which is in essence knife to skin time, and the number of staff present. So in that case, when we're working out the actual cost of the clinician input into that care, then that's where we look at the numbers of staff present times the number of minutes that the patients have been in the theatre. This is where things like electronic patient records become very, very important. Quite often in a paper-based system, you will not have a document of how many people, how many professionals are in a given theatre space at any given point in time. Radiology costs, the number and the type and the cost of the scan. So that's fairly straightforward, as is pathology costs, number, type and costs of tests. Drug costs are separate. They are directly calculated from the actual cost of the drugs. So these are just some of the types of costs and some of the types of methodologies that we utilise to take non-patient facing costs and allocate them to a patient facing cost category. Ultimately, the intention of doing all of that is to lead to something called a patient bill, or what we refer to as a patient bill. Ultimately, whilst the patient doesn't themselves receive that bill, it allows us to have a look at what our patient care actually costs our organisations, and we can look at it by all manner of different lenses. It might be we look by specific hospital site. It might be that we look at the point of delivery. Was it elective? Was it non-elective? Was it a day case? We can look at it at HRG level, so we can look at similar types of conditions and procedures that have taken place and have a look at whether those costs vary across the different specialties that we've got, or even between consultants. So there are a number of ways in which we can look at that data, but that's a fairly high level overview of how the costing process is done. So here's an example for you of how we would approach consultant cost allocation. So we're taking this actually from the basis of what is the overall resource. And for the purposes of a nice, easy calculation, let's say it's a nice, round, even £1 million worth of consultant medical staff cost. We then have a look at what that consultant's job plan is, or what this firm of consultants' job plans are. And we can see that there are 30% of their job plan is allocated to ward rounds, 30% to theatres, 20% to cancer MDTs, and 20% to general outpatient clinics. So fairly straightforward. The activities we then absorb those costs into are 300k into ward rounds, 300k into theatres, 200k into cancer MDTs, and 200k into outpatient care. We then will say, how do we allocate that to a specific patient level? So for each patient and each episode of care for each patient, we will look at a weighted length of stay. So very much like in the previous slide, the cost driver is the unit of currency that we refer to, and it is the way that we disaggregate a large sum of money to basically be specific to a patient. In this instance, the ward round will be a weighted length of stay. If that patient is admitted for 2 days, they're going to get 2 ward rounds worth of cost allocated to them, as opposed to if they're only in for 1 day. So that is how that cost drive works. Very much similar to theatre, it is the surgeon cutting time. If a patient is in for 2 hours versus 1 hour, they're going to get 2 lots of that cost and not just 1 lot of that cost. In terms of the cancer MDTs, it's a number of meetings that the patients was discussed at, very, very similar to the ward rounds. The more times that they come into contact with that consultant's resource, that their amount of time, the greater the level of cost will be applied to that patient-specific bill. And in terms of outpatient care, it's a weighted attendance. So a weighted attendance in this instance will be, was it a first attendance or was it a follow-up appointment? Was it a single disciplinary clinic? Was it a multidisciplinary clinic? So hopefully at this point in time, that gives you an overview of at a very high level how some of those costs are disaggregated from the finance general ledger down to a patient level cost. In this instance, it's actually an episode level cost. However, as you can see there, that is not simply done for admitted patient care. It is also done for outpatient care and actually community care as well. So why is PLIX data important? So PLIX is patient level information and costing systems. It is an approach to costing. It was said back in 2018 by the Healthcare Costing for Value Institute that costing has a major role to play in supporting the delivery of high quality sustainable services across the NHS. NHS organisations need robust and detailed cost data to support them to meet the major financial challenges they face, allowing them to understand their service costs, reduce unwarranted variation, and develop new models of care. Now, I'm not going to just sit here and read this slide at you. In essence, what I would say is in the 5 years since this 5-year plan was put together, all of the challenges that the NHS previously had have only become more exacerbated in that period of time. Not only that, we've moved into different ways of paying for our healthcare, which I'll detail in a couple of slides' time. Suffice to say, the Healthcare Costing for Value Institute felt it was sufficiently important to put a 5-year plan in place called the Costing Transformation Programme to make sure that every NHS acute organisation moved from reference costs, which was a very broad way of doing costing, to this patient level information and costing. And it's that PLIX data, and it's a granularity of that PLIX data that makes it so very, very useful. So some of the national users of PLIX data might give you a feel for how important it's considered. If you're a clinician on the call, you've probably very likely heard of the Model Health System, and just as likely to have heard of the Getting It Right First Time programme. They are two slightly different approaches to looking at data-driven improvements. Model Health System, previously Model Hospital, allows you to look as a hospital or as a ICB at benchmarks of quality and productivity for your particular organisation in comparison to peer organisations, and identifies opportunities for improvement. They utilise PLIX data alongside something called HES data, hospital episode statistics. So utilising PLIX data and HES data, they're able to have a look at how health systems or acute providers set their services up and what value they're delivering for the patient care that they carry out. What are their clinical outcomes like? What does that mean from a financial basis? Are they providing commissioners best value for the public money that they're spending by commissioning services from their providers? The Getting It Right First Time national programme, very, very similar approach in terms of looking at ways to improve the way that we treat and care for our patients, but it's very much a clinical led process. It was set up by a jobbing clinician and has continued throughout the time that it's been commissioned by NHS England to utilise senior clinicians who are subject matter experts to look at how services are run across different organisations and identify what is proven best practice for each particular specialty. NHS England and Improvement also utilise PLIX data, and the National Case Mix, which sits in NHS Digital, also utilise PLIX data. Suffice to say, the point I guess I'm trying to get across is that PLIX data can be useful to many, many different people in many different ways. And I'll go into a little bit of the detail about how it can be used. So we've moved from a world in the NHS where NHS funding was previously delivered through something called payment by results. It was where commissioners would pay healthcare providers for each patient seen or treated, and those payments would take into account the complexity of the patient's healthcare needs. Sam Levy will come on to that in the coding presentation shortly. However, we've moved away from a payment by results model. We'd started moving away from it before the pandemic, but I think the pandemic has accelerated the move to something called an aligned incentive contract, which is an agreement between a commissioner and a provider to work towards the achievement of agreed population health aims across a system or a place. That's quite fluffy. What does that actually mean for providers? So the shift to aligned incentive payments, in essence, mean that providers move from chasing tariff from commissioners to being mindful of whole systems costs and planning. So for a number of years, it was the case that acute providers would try and pull in as much funding as they could from commissioners, whether or not that provided the cheapest possible and best value possible healthcare for a patient. Ultimately, acute providers were keen to make sure that they could get as much funding in as they possibly could. And what it meant is that there was a perverse incentive created whereby you could, as an acute provider, be doing care as a day case, for example, which would have been just as successfully delivered as an outpatient or potentially even in the community. And that was because payment by results incentivised you as an acute provider to do that. Aligned incentive payments are absolutely about looking at what is the cost of care, where can it best be delivered, and across the whole entire healthcare system, how can we deliver that best value patient care. Why PLIX data is important within that decision-making process is the detailed and hopefully accurate costing data can ensure that we understand if us as provider trusts are delivering services that fit within our particular part of the funding envelope that we receive. So aligned incentive tends to be on a block contract basis. So are we delivering care within the financial envelope that we've got to deliver that care? Where it isn't the case, the PLIX data can allow a deeper dive into specific instances of where it might be that improved process or changing pathways or looking at different ways of doing procurement could improve the trust position in terms of delivering that care within the financial envelope that we have got. So that is why it's important from a provider basis. But nationally, what is the picture? Well, the NHS's planning priorities for 23-24 have highlighted recovering our core services and productivity as a key priority for the NHS as a whole. That can be demonstrated by a number of different kind of improvement programs across the NHS that are being put in place to, in essence, try and return to the levels of productivity that we were achieving pre-pandemic. And that is why you will often find people benchmarking data and telling you that you're not as productive as you were in 2019, 2020. That is where things like the elective recovery programme come in. It is very much a case of trying to say we need to be as productive as we were before, whilst maintaining clinical standards that we previously had and improving them where possible. So again, why would you use PLIX data to help in that key priority? Well, costing data, and specifically PLIX, the approach to PLIX utilises an array of trust data feeds and systems data to be able to provide a multi-layered view of our patient care, of how our patient care is carried out. And actually, it is not only the breadth of the data that allows us to analyse a clinical service, it's the depth of the data that allows us to analyse the clinical service in a way that a standard activity or performance report simply can't manage. And very often the cost element is an indicator of inefficiency or a lack of standardisation in the way that we deliver care. So coming from a clinical coding background, I can say that for many, many years, I was advocating the use of clinical coding data as a way to peek into how patients were being treated and what their outcomes were. Were they being treated in a way that reduced the chance of readmission or of surgical complications, for example? Allying that with all the other data sets that is required to do PLIX, to actually carry out PLIX. We've got theatre data sets, we've got critical care data sets, we've got community data feeds, we've got outpatient data sets, we've got population health information like levels of deprivation, for example. We can see how patients have arrived to A&E. Is it by ambulance? Have they walked into A&E? We've got all of that rich levels of data underlying the straightforward, why was the patient here? What did they have done? And how did they leave the hospital? All of those things are very important in of themselves, but with all those additional data feeds and all that additional richness of data that we are required to have in order to do the costing process, the real value of PLIX data lies in the data that we have in order to do the process, not only in the process itself. Being able to do that means that we can analyse and categorise clinical case mix. And we can look by patient pathway, for example, and theatre utilisation all in one consolidated analysis. So if you overlay that with the detail of the costs incurred, it will hopefully give you, as decision makers in your area, an extra sets of information that you wouldn't necessarily have previously. But if we ally that with your detailed knowledge of your own service, that then can give you a level of insight that you haven't previously been afforded. So I'm just about running to time. So in that case, I have got a couple of questions in the chat there. I will look to answer them at the end of the presentation, if that's okay. So what are some of the examples of how Plix data can and has been used? So we've got, I've broken these down into generally the type of discipline that people would be employed by as to the sort of things that would use Plix data for, but all of the Plix data is available to everybody if you're asking the right questions. So for operational purposes, Plix data can underpin service redesign and reconfiguration, can look at cost baselines, which may then feed into business cases. It may feed into benefits realizations of pre-existing agreed business cases. If you're looking from a finance perspective, you can look at cost segmentation. So what are the types of cost? What are those costs compared to peer hospitals? And that's where your cost benchmarking comes in. Looking at a HRG level to analyse how that cost is accrued and how that expenditure is expended. From a clinical perspective, again, very much a pathway redesign. We can kind of measure the cost of certain parts of a pathway, absolutely. But actually, the key thing is to say, OK, where that pathway that is in place that hasn't been followed, does it cost more? Does it cost less? Are the patient outcomes better or worse dependent upon those pathways? So again, cost is a measure. It is not the be all and end all, and it is very, very important that we're looking at balancing measures like readmission rates, length of stay, where possible, patient satisfaction surveys, and linking it into the type of care that we deliver. The effectiveness and utilisation of interventions. So, you know, where we are using support services to support our patients, say a diabetic nurse specialist, for example, do we get better outcomes for our patients? Are they readmitted less? Do they spend less time in hospital? And all of those things are things that drive the cost of patient care down. So what can costing or Plix data offer? It could provide very granular costs. Some of the questions that are in the chat might be covered to some degree by some of this. So we can look at bed day costs. We can have a look at outpatient clinic costs, for example. We can do the end-to-end pathway mapping where there is a pathway ID provided in the data. We can look at and analyse clinical care by specific measures of case mix. We can triangulate different data sets to look at how a whole patient journey happens. We can benchmark at a national, regional or trust-wide level. We can do what is called a detailed service analysis, which is in essence a specialty deep dive. I'm going to give you two examples now about how costing data and Plix data has been used in different organisations. So a fairly straightforward example is at Leeds Teaching Hospital. Their urology service links in with their costing team to have a look at the Plix data to review how two different types of procedures that were in place at Leeds had different outcomes for patients and what that meant on a cost basis. So the two procedures were to deal with an inflamed prostate. The standard way that care was carried out previously was through a TURP, a transurethral resection of prostate. And actually the newer version of how they were being treated at Leeds was using something called a Eurolift. The review evidence that although Eurolifts incur higher consumable costs, they require less theatre time to undertake and can be completed as a day case, meaning that patients no longer require a 3-day ward stay. So looking at that consumable cost in of itself would have suggested that TURP was the more cost-effective way of treating that patient because the Eurolift was more expensive. it is by triangulating that admitted patient care data, for example, to say, okay, the length of stay for that patient is longer when they have a TURP as opposed to a Eurolift. So there is cost that is avoided by virtue of using Eurolift. The same in terms of theatre time, it takes less time to actually do the Eurolift. So overall, the cost of that patient is less, despite the fact that the cost of the consumable is higher at the point of actually treating that patient. So fairly straightforward. None of this is really rocket science. It is more a case of having all this information in one place to look at it in the round. An example of a deep dive, and this is the approach that we take at Manchester Foundation Trust. Maidstone and Tunbridge Wells, MTW, looked at their ophthalmology service and found that it was making a loss of 769k, with the majority of that attributable to their outpatient procedures, which were losing even more than that. So there must have been netting off some profit at some point in time. Whilst that level of loss was still within line of what the targets were at that point in time, they wanted to look at that service and to understand how they could be more cost effective whilst not harming patient care. So one of the areas that they looked at was to look at their day case surgery. And utilising PLIX data, they showed that there were opportunities to increase capacity in day case theatre sessions by, and again, bear in mind, none of this is rocket science, it's all very logical, reducing the number of minutes per case in theatre to the national average. So PLIX data is useful there because actually you're not simply saying, well, reduce the number of minutes that you're in theatre. You're saying there is precedent for actually the national average suggests that we can reduce the number of minutes per case to that national average and be quicker than we currently are. So it feels more achievable than simply saying reduce the number of minutes. Reducing cancellations by 25% to provide additional day case slots, ensuring that theatre sessions which were underutilised by more than 60 minutes were made available for additional operations. That would then remove the need for Saturday waiting list slots as well as some midweek waiting list sessions. Again, all very logical, but the costing team were able to demonstrate the cost of not doing those things. The clinical utilisation analysis that they did showed that the patterns of use of their outpatient clinics showed that there was unused capacity in outpatient clinics in certain locations. So simply by rationalising the number of clinic sites that they had, resulted in reductions in the estate and staff costs that it took to actually run those clinics in the first place. They were looking at their on-call costs for their ophthalmology inpatients, and they found that whilst they had on-call junior doctor cover, which they provided in A&E, it demonstrated that actually only around 140 non-elective patients each year were seen through A&E. So in that instance, they went into consultation to remove that junior doctor cover to result in salary savings. The likelihood is that even if that junior doctor post was no longer in the establishment, that is a reduction in salary savings, but it could be that money or that junior doctor could be utilised elsewhere within the healthcare system to get better outcomes. In terms of those being examples of how PLIX data has been used, is hopefully useful for you to see, but unless you know how to actually get access to that PLIX data, you probably sat there thinking, okay, well, that's all very useful, but how do I move this forward in my organisation? So here is a brief example of some of the types of analysis that you can get access to in something called the Acute PLIX portal that is provided by NHS England. And what you can do is you can look by trust, by point of delivery, so outpatient, inpatient, day case, elective, non-elective, community. You can have a look what your cost opportunity is. And what a cost opportunity is basically to say, if you were to deliver the care that you currently deliver at the cost of the national average cost for that same care, would you have a cost opportunity? i.e., would you be more expensive or less expensive than you currently are And ultimately that tries to identify for you where there's an opportunity to learn from other different providers and to understand how they deliver care to then hopefully replicate that care. So what you can see, possibly not very clearly, but there is a link in the top right hand corner that you can utilize when these slides are sent through, that's the overall cost opportunity picture there for MFT. For this particular one that I'm looking at, there's a £78 million cost opportunity in 21-22. What you've got down here is a breakdown of the type of cost categories. So we're looking at specific areas, MFT, and one of those things is angioplasties. We seem to be more expensive than the national average cost for angioplasties, so we're looking at why that might be. What we've been able to show by using the PLIX portal is that the way that our cath labs are costed at this point in time and the way that we pay for our cath labs seem to leave us with a higher average unit cost for delivering angioplasties than the national average. What we've got on the right hand side here as well is the average length of stay for those patients, and what you can see is the national average is the line across the middle, and the blue column is MFT, and you can see that we have a higher than our national average length of stay. So these are smoke alarms for us to start looking at into our internal data to understand what it is that might be driving that increased length of stay against national average. This is something that anybody who's got that link can access and sign up for an account for. It doesn't require you to be a costing practitioner in order to get access to those. And very quickly, I will just run through, because I believe there are some MFT staff on this. We have this data internally. We can add you to a Microsoft Teams space that has this information at your fingertips for internal models. So I will look to quickly flick through those ones and get to the call to action, hopefully, for each of you who haven't at this point in time come into contact with a costing practitioner in your organisation. Work with them. Please work with them to get the best quality PLIX data that you can for your organisation. Some specific examples: keep them updated when management of services change. At MFT, we've got single hospital service arrangements in place. So one part of the organisation might managerially and financially own the care that is delivered in a different physical part of the organisation. We need to know what belongs to whom. Inform your costing team when used as a clinical space change. So if the specialty that is mostly utilising a ward changes, let them know that that change has taken place, so then we can allocate the costs appropriately to the correct specialty. When a location of a clinic changes, let us know. Let your costing team know. They can appropriately then align the costs to the right services and give you that rich data. And clinically, who does what and for who? For example, have previously consultant-led clinics now become registrar or specialty nurse-led clinics? Again, we can then make sure that costing teams are applying the right level of cost to the right type of care that is carried out. So in essence, who, what and where. The better we can reflect your reality, the better we can support data-driven insights. So I'm going to ask AK and Becky, am I able to answer those questions that are in the chat now, or have I overrun to a degree where we're going to have to move on? I think you might be on mute, AK, or at least I can't hear you.
It might be worth you answering the questions, because then some of them will probably be useful for the next talk anyway and help understanding.
Okie dokie.
So very quickly, succinctly.
I will do my very best for you. Okay, so from the very top, do we have any data? Oh, sorry. It's just scrolled up. Do we have any data telling us the overall cost for a patient and thereby how much non-acute cost there is, so we can move to more community and less acute? If your trust collects community data, MFT does collect community data because we manage community care, then yes, you should be able to look at the cost of the full patient journey from community also to acute provider, whether that acute provider care was delivered in an outpatient setting or an inpatient setting. So yes, you should be able to do that. It would be interesting to have an average cost for an hour of patient contact time in acute versus community versus GP. Again, it all comes down to data feeds. If you've got those data feeds in your organisation, then yes, you can do that. It will very much depend on whether those data feeds are being made available to your costing team. And because that shows up as unknown user, I can't tell if that was an MFT person who asked that or not. So I was answering very much generically. Can you give a specific example of the breadth of data versus standard performance reporting? So I guess what I would say is standard performance reporting, say if it was theatre utilisation as a standard performance reporting, what you're likely to get there is the amount of time that patient was in the theatre, the amount of time they were in recovery, and what type of consumables might have been utilised for that patient, for example. But standard activity reporting tends to be quite siloed in that respect. So what you get is you get that very rich theatre data set, but you wouldn't necessarily ordinarily in those type of reports get the amount of time that patient waited from being admitted to actually being taken to theatre. Were they operated on day 3 or were they operated on day 1? What was the length of stay that patient stayed in hospital after that theatre session took place?
We need to upload that onto Teams and check it works as a macro file.
So sorry, somebody I think is unmute. Somebody's unmuted themselves there. So that's where I'm talking about the breadth of data is because we've got these multiple data sets, we can triangulate them to start to say just because a patient is in theatre less time under one consultant than another doesn't necessarily mean that the overall patient journey has a better outcome specifically because of that theatre element of it. Next question, am I right in saying PLIX can also provide an analysis of utilisation of outpatient clinics? If the data feeds allow, if the granularity of the data that your trust gets from the outpatient data set shows what that clinic was and how many patients actually attended. So if those clinic outcomes were recorded by the people who were in the outpatient clinic, then absolutely yes, you can look at the utilisation of those outpatient clinics. And the example from Maidstone and Tunbridge Wells demonstrated that they were able to do that. They could see which clinics were actually being attended and which had higher levels of DNAs, and that's why they were able to rationalise the locations of where those outpatient clinics were taking place.
Gareth, I'm going to stop you there, Gareth, because I think we're running well over time. And thank you very much. If there are other questions, I will try and address them at the end if I can. But I would like to thank you, Gareth, for your fascinating talk, as always, and introduce Claire Jacqueline, who's the Senior Costing Accountant at Humber Teaching NHS Foundation Trust, who is going to talk about PLIX, but in the context of mental health, which is a slightly more complicated and slightly different way of doing things. Over to you, Claire. Thank you very much.
Hi. Thank you for inviting me today. I'm obviously going to talk about patient level costing and information again. I'm a costing accountant at Humber. I've been with my trust for about 14 years, but I've been doing costing for at least 20 odd years in different sectors, retail, food manufacturing and financial products, but now ended up in the NHS. And I firmly believe that you can cost anything with the right information. But there has to be a reason, a purpose, a so what. We can't just cost things for the sake of it. It needs to have a use. And there's always a trade-off between time and accuracy, but we need to be able to use it to highlight issues and affect change for the better in everything that we do. So in this session, I want to cover a little bit about Humber. What is costing? Why do we cost? Costing in a mental health provider, and a little bit about the patient level costing and understanding the patient journey, and how costing information can improve patient care. And it's been interesting to watch Gareth's presentation and just to see how we approach things slightly differently, being a mental health provider, to the way that the acutes work. So as a trust, we're fairly small. We cover about 765,000 people, an area of 4,700 square metres, all age groups. We cover mental health, community and inpatients, which is what we're going to talk about today. We also have learning disability services, community health and therapy services. We also have a few GPs in our portfolio, and that sort of bits and bits of information. So I'm going to flip through the slides fairly quickly because I have a few to go through. We have about 3,700 staff, around 80 sites, and we're a teaching trust. So we work along with the Hull York Medical School and the University of Hull, have R&D teams, and my trust, as I said, is fairly small in the grand scheme of things compared to an acute. We're about £240 million in turnover. But size in turnover does not necessarily equate to the complexity in what you cost, because obviously that's the number of services that you are costing, or the number of individual patients you are costing, and the number of activities with those patients. So what is costing? I suppose it's a noun if you look at the Oxford Languages definition, and it's the proposed or estimated cost of producing or undertaking something. And in the NHS, that obviously quantifies the value of our resources, our nurses, our occupational therapists, our psychologists, all the consumables that we do, and it looks at how we consume those resources by carrying out certain activities. When we look at costing, I suppose a lot of the historic studies on costing were pretty much defined by Kaplan and different people over the years. He was an American sort of professor who developed a thing called activity-based costing, which wasn't so much looking at absorption costing, where you allocate your costs on a sort of a top-down method, maybe just over the costs of your labour costs, your labour time, but started to look at how you actively cost different things. So you are looking at maybe the number of orders you've processed for your different teams, or you may look at the number of activities. They're not always necessarily the drivers of staff related time of doing something. Today, sort of Wikipedia identifies that describes ABC as a costing method that identifies activities in an organisation and assigns the cost of each activity to all products and services, or according to the consumption of each. It's very much trying to look at what we do, what causes cost, and how we can sort of investigate those sorts of bits of information. What can we learn from it? Seeing that also the Chartered Institute of Management Accounting defines ABC as an approach to the costing and monitoring of activities, which involves tracing resource consumption and costing of final outputs. It's very dry. It's the definition of what costing is, but the reason that we do it is because, as part of being the NHS, we're a public funded body, and we need to explain how we are spending the money as such. There's lots of stakeholders in the NHS, maybe the patients, the regulators, even suppliers of things that we use within the NHS are all interested in what we are doing with the money. And there's only a limited amount of that money in what we can see. Also, part of our regulatory framework in the NHS is that we should be able to, and we have to submit the costs of, sorry, that's flip sides. We have to be able to submit the costs of delivering care to our patients, to NHSE, to be able to say what we do. We are commissioned to do that. So why do we cost? We cost for we cost using the information to make more informed and more evidence-based decisions, maybe about the people that work in our services and how we deliver those services, maybe about the places that we deliver those pieces of care in. In mental health, that's particularly important because, as I said, we've got over 80 different sites. Some of those are more suitable for certain type of illnesses than others. Maybe the patient wouldn't want to go into a really big hospital. It wouldn't work with the type of care that they need. And so we need to be able to understand the impacts of everything that we do and around the care that we deliver. So a little question for everybody. I'm not going to ask everyone to shout out. If we have a team that spends £10,000 more than their budget and a team that spends £10,000 less than their budget, which team is actually doing better? And from that sort of information, I know my financial colleagues kind of would always go for the ones that are overspending and not quite doing as well. But from a costing perspective, that doesn't give me a clear enough answer. It doesn't tell me enough. Because if you're spending £10,000 more, are you actually achieving more within that cost envelope? And at the moment, that doesn't give me enough information. So patient level costing and costing that we do tries to give more information than what clinical managers would do from maybe their monthly budget statements that they look at, where they're looking at actual spend versus budgeted spend. It just doesn't give them enough information. So my next sort of question is actually for the same two teams, Team A and Team B, one spent more than their budget, one spent less, but now you've started to get the number of activities and the number of contacts that each team has done. Now can you tell which team is doing better? And here for this particular example, I've got the average team cost. Well, the average cost per contact for Team A is £180 and the average cost for Team B is £157. And the question again is which team is doing better? And on the face of it, the £157 Team B looks like it could be the potential winner. But again, from a costing perspective, that doesn't give me enough information. I don't know whether the contacts have, say, been for 5 minutes or 2 hours. And actually, even if there was a duration in that sort of piece of time or information, does the longer duration mean that we're giving better care? And certainly not in all cases, because certainly some mental health patients wouldn't want such a long intervention. And the other thing, I suppose, in this is there's no indication of outcome. Have we actually made a difference? Is the patient happy with the level of their care that they've received? Are we making their mental health any better? So another piece of work that came out from Professor Kaplan and Professor Michael Porter at the Harvard Business School in the US was looking at the value equation. They defined value as being the health outcomes achieved that matter to the patients relative to the cost of achieving those outcomes. And without using costing information in your trusts, you cannot begin to define what it is to deliver, or what it is the cost to deliver care. You're also not able to compare that to the outcomes that you are gaining from, or your patients are gaining from delivering that care. So you have no idea on the value that you are providing to users of your services. Another reason of why we cost is obviously there's a big focus at the moment on understanding whether we are providing care fairly and addressing any health inequalities. Health inequalities are the unfair and avoidable differences in health across the population and between different groups within the society. And they arise between conditions within where we're born or grow, live or work or age. And I suppose there are a number of different types of deprivation, whether it's socioeconomic, whether you're unemployed, low income, living in deprived areas, e.g. poor housing, or whether you've got protected characteristics around age, sex or race or that sort of thing. And they all have an impact on your health sort of status or your health access, so your life expectancy or your availability of care or your quality experiences, and also can cause behavioural risks to health. So maybe in certain areas you are more likely to pick up smoking and have the physical health risks caused by things like that. So when we start using information, within our trust at Mental Health, I'm showing you 2 different community mental health teams and their different demographics using data from the Index of Multiple Deprivation. Anyone in the decile 1 is in the areas of the most deprivation. Anyone in the areas decile 10 have the least levels of deprivation. And looking at Team A and comparing it to Team B here, both completely different demographics. One's fairly affluent area, one's not. And we have a different case mix, despite the fact the teams being a similar size. If I add on to that total cost of delivering care to those patients within my trust, within that, for these 2 CMHTs, the total costs tend to follow the profile of the unique patients, which is to be expected. But actually just looking at activity and total cost doesn't give us that much information. And so if I then start adding on to that the average cost per patient in each of those deciles, to understand whether we are delivering care fairly, I would expect each of these charts, bars in the chart at the bottom, to be very similar. Unfortunately, if I look at Team B, I can see that I'm spending probably double the amount in deciles 3 and 4 than what I am in deciles 1 and 2. And all that doesn't tell me why. It shows at the moment I don't seem to be delivering care fairly across all services. I would expect maybe to spend around the £2,000 mark across each of the deciles, but I'm not. And is it because patients in deciles 1 or 2 that in Team B are we're not able to get them to engage with the services? Or is it something else that's driving the care? I suppose data in costing systems sometimes just opens up more questions that can be investigated for us to look at what is going on within a service. So it doesn't always have the full answers, but it does enable you to start investigating things in the way that you deliver care. Maybe there is something in that we need to work on in my own trust. As I said, you can cost anything with the right information. And we do cost at a patient level in the most granular level that we can, using every contact, every bed day, every drug, every supporting activity. But the data that we use for costing actually doesn't have to be perfect. In a mental health ward, or in my mental health ward, we don't collect the number of, or we don't collect contacts with each of the patients. I would love to have that data, but we don't have it. So we use something to approximate that. And we use the clinical notes recorded for each of the patient days that are sort of in recorded by staff members against patients against wards. And for each type of note, we use an approximation of the time that we think it would be to carry out that particular piece of work. It isn't that maybe they've spent 40 minutes doing that piece of work, but we've estimated something that we think on average is the right length of time for that thing. And it comes through then in our data. This is one of my mental health assessment wards. And the 2 charts look at just the top 13 patients in that particular graphic. So I can see the average cost per occupied bed day per patient on the left-hand chart slowly deteriorates, but actually none of the patients in the left-hand chart are in the most expensive patients in the right-hand chart. And actually, all the patients in the left-hand chart were really part of only in the bed for a day in this particular piece of information, because they were part of their assessment phase in that thing. And when they're being assessed, we are recording a lot more clinical notes and clinical activities against those sorts of patients. If I move that information on, I can see that the patient that was actually admitted to that ward for the longest length of time wasn't the most expensive patient to treat for us. If I hadn't used anything like clinical notes, the average cost per patient day would have been the same for us across all patients, because we have nothing else to break that data down. We looked at things like observation levels. So when we go in to see a patient, do we have one-to-one OBS or constant OBS? Is there always 1 or 2 staff or 3 staff going in to treat that patient at a time? Because sometimes you have to go in or attend the patient with more than 1 staff member. But we found that using the clinical notes for us, although it is not perfect information, it gave us a better understanding of what was going on within the ward. And obviously each type of note is a type of activity that has been recorded. So I keep coming back to the point of you can cost anything with the right information, but the difficulties in mental health services, and I'm just going to discuss 2 or 3 of them, include the accurate recording of data to report on costs with. I know acute services are now moving away from payment by results, but the introduction of payment by results pushed the issue of recording data accurately because they were being paid by it. But for mental health services, we've never had that payment by results tariff. Information was recorded pretty much if we were able to and not quite too busy to do it. And we certainly don't have clinical coders. So anything that gets recorded in a mental health service is recorded by the clinical staff, whether that be a nurse, a healthcare assistant, a consultant, it can be anyone in there. Another major difficulty in mental health services, costing mental health services, is grouping or categorizing what you are costing. Because mental health services are probably not as easy to define as the acute. Patients can often be with you for many, many years and not just a quick hip operation or that sort of thing. So it becomes difficult to make meaningful comparisons. I was always explained that a patient may be diagnosed as having a problem. And the example I was given was if you had your right hand amputated, your level of need in services would be different depending on whether you were right or left-handed in your care afterwards. For mental health, it's very difficult to define the level of need that you have for your care. And if we cannot define the right groupings and categories to compare patients together, everybody's an individual and everyone is at a different point in where they are in their journey. Some may have only just started, others are in the middle, and some may be coming towards an end if we are able to help and discharge them in maybe some of the IAP sort of therapies, talking therapies where patients tend to be with you for a shorter duration. So in mental health costing, the landscape is changing. There used to be the currencies which in acute terms would have been the HRGs, but for mental health they were care cluster currencies, and these have been scrapped, and in their place mental health currencies are being developed. These are called mental health and neurodevelopment resource groups, but they are only in their infancy. And this is a slide I've stolen from NHS around the different resource groups. And the very, very top level, they are to be defined from data that is recorded within mental health patient systems. But As I said before, we don't have clinical coders, and it does rely very much on the data being in the system to place patients into the new mental health resource groups in an accurate way that we can use for comparisons. Mental health resource groups for adults are looking at being split into inpatient currencies, community currencies, and crisis currencies, and some sort of assessment currency unit. But there's certainly information on future NHS platforms around this, but it's not something that I'm going to cover in any great detail today. And the final difficulty in costing mental health is measuring and costing outcomes. As we said before, value is the health outcomes achieved that matter to patients relative to the cost of achieving those outcomes. Costing is not all about counting the widgets of care. It's very relatively easy to identify in a queue, maybe if you've made a difference, than it is if you've made a difference in a mental health patient. So if you've done a hip replacement, you can probably measure whether somebody can walk after an operation or they're no longer in pain, but how do you measure that within mental health services? So have we made a difference to the patient? There are things called PROMs, CROMs and PREMs, so patient reported outcome measures. These tend to be sort of questionnaires that ask about your health and well-being, things like recovery quality of life or goal-based outcomes are different measures that are used. Dialogue's another one. There's also clinician reported outcome measures and the patient reported outcome measures. And it's all about how you bring this information into your costing system to demonstrate whether you have made a difference and costing those things. It can be quite tricky sort of in the mental health setting. So I suppose from patient level costing, it's a change in the costing methodology to a bottom-up approach, which allows for improved clinical engagement by discussing the actual patients rather than averages, and better understanding of costs, as it will be able to compare cost buckets rather than just averages. So in a trust for costing, we follow the NHS approved costing guidance, which looks at things like materiality, data information, and engagement as their costing principles. And we try to cost using these, focusing on the big ticket items to begin with until our costing systems become more and more useful. For me, engagement is one of the biggest areas that I think all costing practitioners need to have. I can cost whatever I think, but if it's not useful to services or my managers or my ICB, the stuff that I'm doing is pointless. So as a costing practitioner, we use patient level information and costing systems to do all the number crunching, to do all the sucking the data out of your electronic patient records, out of your room booking systems, out of anything that has information and activity information in it. And we put that information into our costing system, press a button, it crunches it all through with our allocation methods and gives us the costs at the most granular level. We then use that data and feed it into our software reporting software. For us, we use a Power BI software because that's the trust-wide reporting tool. And another, I suppose, as a costing practitioner, we have to have some sort of knowledge of SQL coding, which allows us to pull data out of our data warehouses and into the costing systems in an easy format. But the biggest skill that costing staff need is to build relationships, because without our information management colleagues, we can't build a costing model. Without the services, we don't know how to allocate the costs and how to report the data back to services so it can make a difference and they can make informed decisions from it. We certainly like to build relationships with other knowledge experts, because in costing teams in trust tend to be fairly small. In my trust, there's only 2 of us out of, what was it, 3,700 odd staff. And we like to build relationships with our stakeholders, who making sure that what we develop provides an answer to a question that they have. This might have been my NEDs, my non-executive directors around high level managerial stuff, or it might be within teams around how we are delivering care. Can we do it a different way? Can I compare team A with team B, and look in that way forward? So from my perspective, in my trust, pay makes up the largest percentage of our total costs. But when we talk about the approved costing guidance, there's actually no 100% foolproof way that people have told you must cost in this way. And I've seen a couple of different costing methods used to allocate costs, and each might be slightly more suitable for a different setting. So if you are maybe for this one, I think might be worth using if you are allocating costs, say in a theatre where you've always got the same sort of mix of surgeons and anaesthetists and nursing staff or whatever. But it doesn't necessarily work as well if you are working in a mental health team where when you will go to visit a patient, you are not one of 10 team members. You are a single person to go and visit and make contact with the patient. So the average sort of costs don't work in this instance. So this method takes the total pay and divides it by the total activities, whether that's by minutes or whether it's by counts. It have seen it in both ways. But although it's very, very quick to do, I find a major disadvantage of this occurs when there's low activity recording. So from my perspective, if staff member goes to see patient X, but only records one patient activity and then goes off on sick with full pay, in this case, it would allocate all of the pay cost to that one patient over inflating the pay cost. And so in my trust, we don't use that methodology because it doesn't work necessarily for us. There is a second methodology that we use, which is a 2-stage approach. And here we work out a cost per minute for each staff member based on their whole time equivalent worked, and adjust it to take out any time that they wouldn't ever work clinically. So they don't work holidays, they don't do work for training, they will have an element of sickness. So we work out their available minutes cost, and we apply this pay rate to every minute, to every patient that they record. And this includes our consultants or our nurses or everyone. So everyone has, or even our agency staff, we work this out for. So if a staff member is recorded so many minutes, we allocate a pay cost to those so many minutes. Generally, and in fact, probably 100% of the time, this doesn't allocate the full level of a staff member's pay. It maybe allocate 50% of it or something like that, direct based on their direct minutes that they've recorded. So that's why I call it a 2-stage approach. So the second stage then, for any of the pay costs that we haven't allocated via stage 1, allows us to allocate it to the patient's activities in that team. So it doesn't then, if the patient has had one contact by a staff member and then that staff member has gone on sick, the remaining pay becomes almost overhead to that team, and not a cost to that one patient that they saw before going. I guess the benefits for this does mean that we think it's a fair reflection of the way we allocate pay costs of staff members. And it also allows us to do some things like we call resource usage monitoring, so we can see staff members' resource usage, so their amount of available time and their pay costs relating to that, and as to how much of their time or cost that we've allocated directly or indirectly. So there's 2 staff members here that recorded differently. Why is only one recording 51% of their time versus the other one recording 75% of the time? And this is their available time. I wouldn't ever expect anyone to record 100% of the time, because people don't always do everything in mental health that is recorded clinically. So in this, the other percentage of time under the 80%, we would probably say they might have had some meetings in that. Maybe I could take that out of the available time, but we don't in this instance. But the main disadvantage of doing this at such a granular level is it takes time and effort, and both to collate the data and to calculate the results. So the more that we make our costing models complex, the slower they tend to become. But from our instance, we like this method of you allocating pay, because it is our biggest cost and we want to allocate it the best way that we can. So for patient level costing, obviously pay is only is one part, and we have to follow different allocation methods for allocating our overhead costs to our services and then to our patients that have used those services. And I'm glad I agreed with Gareth earlier. So for our estates and capital costs, we tend to use the floor area of each of the buildings and the time used within each of those rooms. Since COVID occurred, staff work a lot more flexibly in mental health. And so where before we had estates with rooms that were pretty much finance would always use this room and children's services would always use this room, now that's a lot more fluid, and we use room booking apps. So we have exports of data from the room booking apps to say Joe Bloggs has used this room from 10 till 12, and it allocates the costs to that staff member who's booked the room, and then to their patients that they have then sort of seen after that. And HR, again, we use whole time equivalent, as did Gareth's, which I'm pleased to see. And there's certainly lots of other methods. The NHS approved costing guidance has a full technical specification document that tells us how to allocate our overheads so we're all consistent. And that's costing processes 2.2. And for anyone that wants a bit more of an advanced allocation method, they can use costing processes 3.5, which gives superior and alternative permissionable substitutes. So patient level costing, understanding the patient journey. By costing at a very granular level, you can aggregate back the data in a variety of different ways. What I've got on screen at the moment is one patient's activity during last year. Each of the different lines and dots represents a different team. And overall, I know that this patient cost me £132,000 to treat in the year. They saw GPs, they saw our community mental health team, they saw our mental health physio team, they saw our mental health crisis team, they saw psychology teams, and they had a few inpatient admissions and ended up at the end of the year in one of the units. So probably not the best journey to demonstrate, because that patient has deteriorated, requiring an inpatient stay. But you can slice and dice this data in a number of ways. And I can view the same data in a number of different ways. So then I've got, so on this one, I can see the types of activities that have happened month on month, whether it's face-to-face GP appointments. The thing here I've got is called non-contact activity, and that in our trust is called supporting activities. Because we are a mental health trust, we may travel to see the patients, and that would be included in there. So travel time would be included. If we've written up clinical notes about the patient, it would be included in there. I would generally expect more non-contact activity to be recorded than contact activity. There's obviously bed days, telemedicine, telephone. You can also see the patient bill in some form of income and expenditure statement, a patient bill that breaks down the costs of delivering that patient care. but that's just one of the few ways of slicing and dicing the data. I could have done it by setting, by location, by staff members involved in the care. Did we travel to them? But at the moment, I don't have outcome data in this information. So costing information in mental health isn't perfect, but the more that I'm sharing it in the trust and the more it becomes reviewed, the better it becomes. We've had a number of, I suppose for patient level information and costing, we've only been publishing it within the trust in the Power BI reports where staff can access it for a couple of years, where our acute colleagues have been doing it for much longer. But it's led to things like improvements in internal processes like data validation and entry validation. So making sure that we record the data first correctly. It made us look at things like number and frequency of DNAs, because obviously if we're going to see patients out and about in the community, we change the process slightly to make sure that we don't go before ringing, so we don't waste travel time, and also reduce the number of expense claims for travelling. We look at reviewing the care given, or we've looked at reviewing the care of some of the patients that we've got. We did a focus on particularly on high cost patients, looking at whether they were in the right mental health team. Was it the appropriate service for them? Would they be suitable in a different service given the frequency and the high volume of contacts? And we've looked at things like guidance on how we record data, because we found that we didn't have the best standardization of data entry. And so it was trying to improve on that. But the main focus in my trust at the moment seems to be looking at capacity, demand and productivity. What are we doing? When are we doing it? How are we doing it? Can we compare staff member X with staff member Y? And actually, what's stopping staff member X doing something that staff member Y is able to do? Is there something in the way that we are delivering care that's preventing us from being more productive? So we've been certainly looking at that sort of thing in our internal processes, which is leading to better costing information. And there's certainly dashboards and things that allow us to start looking at more variation in clinical practice across teams and services. There's data around averages, highest and lowest cost, the range of cost per contact, average time on caseload, the ability to cope with capacity and demand compared to other similar sized teams of the same function. We can obviously compare whether similar staff are delivering the similar number of activities, and support of referrals and discharges by team and the typical contacts per episode in a like-for-like service. So they're sort of the easy ones to focus on. But at the moment, as I say, we've yet to bring in the outcome measures, and until the mental health resource groups come through, it's a little bit about like comparing apples and oranges when you're trying to do national benchmarking and things, because everybody's teams are set up slightly differently. Some are more multifunctional, others are more specialist, and actually often it looks like we're comparing apples and oranges. So for improvements in patient care, it does enable you to make comparisons and see variations and highlight potential areas of concern of good or bad practice. Earlier I looked at the health inequalities between two of my CMHTs, but that does need some further work on it. It also allows us to look at planning, so information. So if we know that having this number of patients in our services requires the certain number of resources to deliver that care, we can flex that activity. And that does become very key when nationally sometimes health promotion campaigns go on and suddenly you get a massive growth in, say, dementia assessments being requested or that sort of thing. And you can then try and focus and plan what resources you need to deliver that amount of care. But to do that, you need to take your data back to almost comparing each patient from a time zero when they started with you, what it took to assess them, what it took to treat them, what it took to deliver that care, and how you can make things better. Obviously, in mental health, not all patients will get better, and particularly in your organic services where there will be deterioration and progressive deterioration that you cannot stop, but it's how you make your patients live better with the prognosis that they have. We certainly can review. I know we internally look at it for budgeting and that sort of thing, but externally, if that information is available from IICB or other trusts within my patch, I know we did some work in the past around frequent flyers at A&E and working together with the acute trust to help care for the patients that keep turning up at A&E that have a mental health issue rather than a physical healthcare issue, and how we structured the teams that we had based in our local acute hospital. It certainly allows you to focus on productivity and see the areas of overlap and the duplication, so you can maybe streamline what you are doing. I know we've certainly had some areas where we seem to continue to make assessment after assessment after assessment, and actually some of those didn't need to happen. Mental health patients often don't just stay in one team, they can be open to multiple teams, so it can at times be difficult not to duplicate. And obviously I mentioned earlier to working with other organisations to improve the patient care and across providers. So I suppose that was there any questions? And sorry, I've not been able to see any of the comments while I was presenting.
Thank you, Claire. I think some of the questions have been answered as you went along. Yeah, I think there was a question related to tariffs, but I think Gareth has put a link on to the kind of unbundled stuff, so I think that made sense for that. So is there any other questions for Claire? If not, we'll move on to the next speaker, only because we are running increasingly over time. But thank you very much, Claire. PLIX, both in mental health and in acute systems, is a quite a complex but a very important subject, and I think it's a key way of clinicians and operations teams engaging with finance and using that data as an important source to improve their pathways and systems. Hence, I'll let both of you kind of continue on until you fulfilled it, because I think it was really important. But another key tenet of this whole process is clinical coding, and how we record that data, which underpins a lot of the PLIX data. So we've got Sam Levy, who's the Deputy Head of Coding within Manchester University NHS Foundation Trust, who I believe, yes, there is going to come and talk to you about the importance of clinical coding. So thank you very much. And over to you.
Everyone, thank you very much for having me. I'll share my presentation. There we go. Hopefully everyone can see that. Just trying to get you guys back up on the screen. Yeah, so I'm here today to talk to you about clinical coding. So I'm going to talk about what clinical coding is and why we do it, and then the sort of more specific context of how coding relates to income and finance. So what is clinical coding? That's the question we kind of get asked an awful lot. It's really misunderstood. sometimes that's our fault for not doing a great job of getting out there and saying what we do and speaking to people and engaging. And sometimes it's to just part of the industry itself, and the language used in the industry is not very accessible. But what clinical coding is, it's the translation of medical terminology into alphanumeric codes. So in essence, what that means is we have clinical coders whose job it is to read all of the relevant documentation for a patient's hospital stay. And they take that information, they extract the diagnostic terms and any procedural information, and they assign ICD-10 and OPCS4 codes, which correlates to those diagnoses, any comorbidities, and any procedures, and that builds a coded record. Those ICD-10 codes and OPCS4 codes, they underpin the HRG logic, and this drives the National Tariff Payment System, or the NHS payment scheme. Some of the other uses for coded data are what we call depth of coding. So that's the number of ICD-10 codes. This can be used as one indicator of complexity, and we can use that for case mix analysis and activity planning within trusts and across regions and nationally. ICD-10 codes are also used for the risk modelling of the national mortality indices, HSMR and SHINI. I'm also going to talk to you a little bit about coding improvement. This is something that we've done at Manchester for quite a number of years, but it's becoming more and more commonplace within coding departments across the country. And it kind of highlights the importance of coding and how people are really starting to get to grips with why coding matters. So coding improvement generally refers to a quality improvement program. And it uses lots of different tools to bring about tangible benefits to the trust and to the department itself. At our trust, one of our big focuses is around monthly schemes, and these are post-coding processes where we validate what's being coded against potentially missed information, whether that's by accessing information that's in clinical systems that coders don't have access to at the point of coding, or taking information that's been agreed in at a local level, in a local policy, but recognizing that the time it would take a coder to try and access all that information and boil it down at the point of coding is very long-winded, whereas a post-coding process or an exception report can be used to distill that information a lot quicker. So we re-access and add the codes back in retrospectively. It also involves engaging with clinicians and divisional teams to educate about the importance of coding. So it's not just about going back and adding more codes in, it's about trying to get it right first time, getting stakeholders to understand why it's important, a little bit like this, but more on a local level. We also do ad hoc projects, so specific teams might be facing a specific issue that they need help with. We as a coding team can say, well, the coding data can help with this, or we can create a solution to a potential problem using coded data. Things like that would be maybe redesigning smart forms and things like that can be used at clinics where we've got much more concise information that's targeted toward that specific service and maybe has clinical codes aligned to it, so everyone's got visibility of what the code should be. We generally also attend hospital mortality meetings, and that's, again, because the coded data has an impact on mortality metrics, it makes sense that clinical coding has a presence at those meetings to address any concerns before any alerts are raised. As well as understanding what coding is and why we do it, I think it's also important to look at what coding isn't, because sometimes the coded data isn't the right place to look, or sometimes people can expect too much from the coded data. So although it's called clinical coding, coders aren't clinically trained. So decision making has to be the responsibility of clinicians. What that basically means is if it's going to be coded, it has to be documented. Coders can't make assumptions regardless of how experienced they are within the field. Coded data isn't granular, so ICD-10 and OPCS4 are classifications, so they're designed to group similar entities together, and that supports statistical and epidemiological analysis, but it doesn't get into really, really specific detail. And I've got a couple of examples to show you in a couple of slides' time to explain that in a bit more detail. It's also not catch-all. So clinical coding deals with admitted patient care, the APC data set, and that's inpatient activity and day case activity. We don't code outpatient activity, and that's true for the majority of coding departments across the country. Some coding departments will take care of the outpatient activity at their trust if they've got capacity, but mostly it falls outside of the remit of the clinical coding department. The workload of the inpatient activity tends to be too great to incorporate outpatients as well. So an example of one of the great uses of coded data is this. So you can have the same thing documented in 3 different ways, but actually it all comes down to the same ICD-10 code. That's really useful at making your data comparable. So it doesn't matter if a doctor always writes an MI as an MI, or at another trust they always write it as a heart attack. It doesn't matter. It will always go to the same ICD-10 code, so you can measure and compare heart attack rates or MI rates across the country really easily. But one thing we found post-COVID is anecdotal evidence that patients are getting sicker. And unless there's been a development of additional conditions, so if we increase that depth of coding that I mentioned earlier, the coded data can't show that. It can't show the genesis of a single disease, because that's not how a classification is designed. And that's where terminology becomes a better place to look. So if we take an example here of coronary artery disease, a patient was diagnosed with coronary artery disease in 2020, and the plan was they were going to be admitted for a stent. Then the pandemic hit and the surgery was delayed. This is the code that would be assigned, this I-25.1, and there'd been no mention of a procedure because they were never admitted for that procedure. It never happened. 3 years down the line, they've now got triple vessel disease and they need a bypass. So the patient's much sicker and they need more complicated surgery. But their coded record will still just show this I-25.1. It's the same code. So there's no indication that the conditions got worse. And the fact that they've had a bypass surgery coded doesn't compare to anything, because there was nothing in the clinical coded data previously to say what they were supposed to have. Whereas if we look at something like SNOMED, which is a clinical language, it has that level of granularity. Here we can really boil down to the level of vessel disease. So when we want really, really granular data and we want to look at trends like this of the impact of COVID, it's not always the clinical coding that's the most useful source. So it's just worth sort of understanding that while clinical coding has great uses and there's a lot that it can be used for, there is certain limitations to it. Now we're going to look at clinical coding, how that drives clinical income. So this is a timeline of the payment system over the last 20 years or so. So up until the COVID pandemic hit, we were on the payment by results model, which was trusts got paid for the activity they delivered, and that was underpinned by the clinical coding, which drove the HRGs, and those all had tariffs associated with them. And that's how trusts got paid through the commissioning data set submission into the secondary use service submission. When the pandemic hit, that just sort of became an impossibility to maintain. There was no real tariff associated with COVID patients, and the case mix office didn't really know what to do with the HRG for that cohort of patients, and activity levels just became very strange during the pandemic. So for the first part of the pandemic, we were on block payments based on activity levels from 2019, 2020, and that was it. Then in 2021, we went to the aligned payment and incentive program. That was block payments with variable elements to support elective recovery. So all of the non-elective activity was still paid for on a block payment, and a percentage of the tariff value was paid for elective activity. There was a lot of problems with API when it first came out, and a lot of trusts didn't subscribe to it because it just wasn't, there wasn't a lot of incentive for the elective recovery element for it. And there was parts of it that seemed quite punitive for not carrying out enough planned activity. So it wasn't adopted by all trusts. So that brought us into this year, when there was a consultation and the 2-year national payment scheme was developed, which is a much closer alignment to previous PBR tariff-based payments for elective activity, day cases, outpatient first attendances and outpatient procedures, and block payments for all the non-elective activity. Worth commenting here, because it's something I've heard a lot since April. A lot of people will say, oh, we're back on PBR, and just be careful with that terminology. We're not quite. We are sort of for electives and day cases, but we're not across the board on back onto PBR. So tariff versus cost. I know you've already had the costing presentations, but it's worth just having a discussion about how closely related tariff and cost are and how they form an income circle. The tariff is what I deal with within clinical coding, and that's the price tag that's associated to hospital care. It's the sum payable back to the trust. Cost is how much it costs the trust to deliver that care. So the clinical coding determines the tariff by generating the HRG. But the tariffs themselves are created from the costing data, which is submitted annually by each trust. So there's a really, really close link between tariff and cost. So I've spoken quite a lot so far about HRGs, and I'm conscious I've not actually explained what an HRG is. So an HRG is a healthcare resource grouper, and that's clinically similar treatments which use comparable levels of healthcare resource. So rather than giving every single ICD-10 code and every single OPCS4 code its own individual tariff, they're grouped together to say, okay, there's a similar resource implication for this kind of treatment or for this kind of diagnosis. So this is the tariff associated with it. And it just makes it a lot more of an easy model to manage. They are tiered generally according to a CC list. And that's to recognise that, yes, two patients might have the same diagnosis and therefore have the same base HRG, but actually they might have very different histories, and one patient might be much more complex in terms of their comorbidities, and therefore the cost of caring for that patient is much higher. So the tariff associated with the care also needs to be appropriately higher to cover those costs. So that CC list creates a tiered structure within a base HRG, and that can drive the tariff up on the points-based system. So an example is this box here. So the base tariff is AA50, and it splits it into adult patients 19 years and over, and paediatric patients at the bottom half are 18 years and under. And as you can see, as the CC score changes and increases, the number on the right-hand column also increases, and that's the escalating tariff based on the complexity of the patient. So the CC score indicates the complication and complexity. The higher the number, the more complex the patient is, and therefore a higher tariff is associated with the care. The HRG grouper is a wonderful piece of algorithmic logic, which essentially is a sausage machine. So admission method and length of stay are two factors that are taken in. Then the primary diagnosis, which is and the comorbidities and the procedures, that's the clinical coding, goes in. Some maths is done in the middle, and out pops your HRG at the other side. And an HRG has a tariff associated with it, and that gives us safe and sustainable clinical services, or so we'd like to think. So comorbidities are sort of it's where the battle is lost and won for me, really, comorbidities. So I can't harp on enough about comorbidities. So I mentioned depth of coding right at the start, and what depth of coding means is comorbidities. What are the other conditions that have been coded for this patient? So like I said, HRGs have got this tiered structure, and comorbidities give that indication of complexity. So at a very basic level, a higher number of comorbidities gives a higher depth of coding, which gives an indication that that's a more complex patient than someone with less comorbidities. Within the HRG logic, that's also factored in and actually given a hierarchical scoring system, and that drives through the tiers of each base HRG to give a more specific view of the actual complexity associated with that HRG. Poor comorbidity reporting, though, can result in unrealised income, and that's one of the biggest risks. So the medical definition of a comorbidity is concomitant but unrelated pathological disease process, and it usually indicates the coexistence of two or more disease processes. For a clinical coder, it's any condition that coexists in conjunction, whether it's an additional acute condition alongside the primary diagnosis, or whether it's a chronic condition that the patients always had and they had it before admission, but it affects the management of the patient during that episode of healthcare. And that's why it's important to record it, because it's affected the management. It's required additional medication, additional nursing time, anything like that. It's required more care than someone who didn't have those comorbidities, and that's where the impact comes from. We access the whole medical record for that current admission, and we read all of the documentation, and we will find as much information as we can to make sure we've got a really accurate coded record and all of the comorbidities are recorded. But like I said, we're not clinically trained, so it has to be reported by the responsible consultant for us to be able to code it. We can't make an assumption. So I mentioned before that HRGs drive safe and sustainable healthcare. Here's an example of where that might not necessarily be the case if comorbidity recording isn't perfect. So on this left-hand column, we've got our base HRG. So the patient has a primary diagnosis, but no other codes associated with it. So if we get this HRG of LA09Q, that's got a really low CC score of 0 to 2, has a base tariff of £924. The market forces factor uplift for Manchester is 5%, so it's an additional £50. We get a total of £974 for that patient. But within the nursing notes, there was a frailty assessment done, and the patient was documented as scoring quite highly on the Rockwood score, and they're clinically frail. They also had a low HB and had a diagnosis of anemia. These two codes keep you in the same HRG of LA09, but they've driven us up into a CC score of 3 to 5 and escalated that overall income to £1,838. Then we ran our coding improvement schemes at the end of the coding cycle, and we found that the patient was also hypokalemic. They had low potassium, and there was a nursing assessment done that identified that they had difficulty walking and they needed assistance when they were moving to the bathroom and things like that. And the CC score is now escalated to 6 to 8, and the tariff has gone up to £3,076. So what I'm trying to highlight here is that this is information that was always existent within the patient's medical record, but if it wasn't documented in such a way that the coder could code it, we're not going to realise the actual tariff that we should have got. So the cost of delivering that care could always have been the £3,000 because these conditions on the right-hand side were always present. But if they weren't documented and weren't captured by the coder, the tariff that will be achieved is only £974. So the tariff will never cover the cost of actually treating the patient if those comorbidities aren't captured. Likewise, we've got exactly the same thing for procedures. So there's a huge difference in the bottom line here in the tariff associated with these procedures. And the only difference between the coding is this fourth character on the Y79 code. And it's all that's changed is the artery, the actual named artery that's being accessed for the surgery. So one is the femoral artery and one is the aortic artery, and there's a £2,000 difference in the tariff. For me, this highlights two things. One, the importance of the coder getting accurate. That's a really easy typing error to make, but it's got a huge impact. Coders have got to pay attention and they've got to make sure that the codes they input are correct all the time, but also the quality of the clinical documentation. The difference it can make by specifying the named artery rather than just a transluminal approach is huge. So clinicians also need to be aware of the importance of being as specific as they can in the information they give us so we can get the most accurate code and get the most accurate tariff associated with that as well. So we'd like to say that it's reasonable that if a patient's got a long-term or a permanent condition, something that it doesn't go away once you've got it, we should see a consistent pattern within the medical record and across the coded record that patient's always going to have that condition, it's going to follow them. Sadly, about 10% of admitted spells are identified as missing comorbidities that we'd expect to be persistent. So it really is a big deal, comorbidities, and that's why I harp on about it so much. I'm not joking when I say it's where the battle's lost and won. So how do we address the issue? How do we translate that care? So there's awareness of terminology. Like I said, it's important that clinicians understand how specific they've got to be in what they write and that they've got to document everything and make it accessible for coders so that we can extract the information. But it's also about understanding the terms that we can and can't use as coders. So the list can vary slightly from trust to trust because there's no fixed rules nationally. But generally speaking, coders can use terms like definitive diagnosis. We can use things like treated as because it indicates that actually a resource is being used. Probable diagnosis, likely and presumed. Things like that can be used as diagnostic statements. So if a condition is described in those terms, we can code it. But we can't code things described as differential diagnoses or a query of a diagnosis or suspected, because they don't give enough clinical certainty that we can then say, okay, it's safe to assign that code. So it's understanding that the language that is used when describing conditions, can it be coded? And it's always worth having a conversation with your coding department to say, what are your policies around the language that you can and can't use? Some trusts don't use likely. Some trusts do use likely. We've recently started using impression at our trust based on the implementation of our electronic patient record, and impression being a term that's being used widely across documentation within the EPR. So we've adopted impression as a term that we can use after conversations with clinical teams. Also, we can't interpret results. So in the same way that we can't make clinical decisions based on information and assumptions, we can't interpret test results either. So most people might know that high BMI indicates obesity, and that's a fairly easy one. But interpreting an EGFR result and knowing if that indicates chronic kidney disease, that's very much a clinically trained skill. And so seeing this information on the left-hand column, we can't take a diagnosis from that. We can't look at a troponin score and say, okay, this patient's having a heart attack. We might be able to guess it, but we can't code it based on that information alone. We need it to be in definitive terms that the troponin score is high, this patient is having an MI. Then we can code it. It has to be spelled out for us to be able to code it, regardless of how obvious it might be. Slide doesn't want to change. There we go. So just another example, just to labour the point a little bit more about this. So we've got a case study here. It's a patient who's had a fall and had a periprosthetic fracture, and they develop an infection during their hospital stay. So here we can see that these are the codes that we've, based on the information we've got in the body of this text, these are the codes we've assigned. So we've got the periprosthetic fracture caused by a fall. We've got the urinary tract infection caused by E. coli, and the patient is documented down here on the left-hand side as having type 2 diabetes and osteoarthritis of the hips. And then they've also had a CT scan. And that gets us this, £1,824. It says BMI there is 34, and there's a long-standing EGFR level of 45 to 59, but that's meaningless to a coder. That doesn't give me any information I can code. It doesn't tell me a diagnosis, so I can't add a code based on the information. If, though, that BMI 34 was then confirmed to be obesity, and the EGFR score was confirmed to be CKD3, they are then codable diagnoses. So I can add the two additional codes in down here on the bottom of the table, N18.3 and E66.9, and that's pushed the tariff up to 2,926. That's more than £1,000 more. This just really indicates that information was there the first time round. It just wasn't in a way that a coder could take the information and assign the codes. So the income will have been missed. The cost of treating the patient was the same, but the tariff received back will have been lower because the information wasn't in a codable format. This is a little bit less of an issue as more and more trusts adopt electronic patient records, but handwriting, it's a running joke within coding departments of being able to read and interpret clinicians' handwriting. But this endoscopy report kind of highlights the importance of it, that it has to be legible. If a coder can't read what's on the page in front of them, then they can't assign codes at all. At worst, at best, there's limited accuracy in the codes that they can assign because they'll be picking out the odd word that they can figure out. Like I say, it's becoming less and less of an issue as we move into electronic patient records and we're using more digital formats. What we find though, and what the risk is that humans will always try and shortcut a system. So even though they might be using a digital format, they will avoid filling in certain boxes, or they'll use more abbreviations because it's quicker to type. So the information might still be inaccessible, just in a different way to bad handwriting. So it's really important to make sure that the information that's being presented to coders is clear and it is concise and it is legible. Here's an example of sort of the ideal kind of op note. So it's separated into sections, clearly headed, typed so it's easy to read, and it also has a lovely anatomical diagram so the coder can actually reference the parts of the liver that are being operated on whilst they're reading the op note, and they can make sure that the code assignment is the most accurate code possible because they have all of the information there in a really easy to read format. So what am I saying? I'm saying clinicians have got to work harder to get it right. No, of course, I'm not saying that at all. Clinicians' jobs is to treat patients. Patient care is the #1 priority of clinicians. It's the job of admin teams like clinical coding, like costing, finance teams to engage with clinicians, to go out and to explain what our needs are, how we need the information to be presented to us so that we can deliver the best possible outcome, so that we can ensure that our role as it relates to patient care can be as optimized as possible in supporting clinicians in their role to support patient care. And that is everything from me. Are there any questions?
Thanks, Sam. Any questions for Sam? No. Okay, thanks very much. We're going to have a slightly shorter break. Oh, there is a question, but I'm just going to finish this comment first. We're going to have a slightly shorter break for 10 minutes as we're running over. As I know people are they're kind of towards the end of the day going to be dipping in and out and have other commitments and various other things. And I have a feeling that my session at the end will run over because of the knock-on effects of everything. But if you can't attend for any reason, then that's fine. All the sessions are recorded, and so you'll be able to watch them back at a later date if you wish. And then you can contact us via any of our email addresses, or contact the one NHS finance team who will be able to pass the message on. So very quickly, Sam, who codes outpatient activity if not the clinical coding?
Usually it will be the outpatient clerks that do it. As EPRs come on more and more, it's becoming an automated process.
Great, thank you. And then do AHPs have a role in documentation? I think there's a question.
Yeah, everyone who can document within the medical record, we will read all of it. So it could always be relevant. If the patients had physiotherapy or had occupational therapy and speech therapy, there are codes for that, and we will code it, and it does make a difference.
Yeah, I concur with that. So we found in our trust pre-COVID, but we found about 10 to 12 million pounds worth of uncoded data based on therapy, so occupational health, physiotherapy, and sight, speech and language that weren't being coded. So that accumulated to roughly about $10 million, 10 million pounds. God, American. Where can you find guidance for clinical notes records to support coding?
I'd advise in the first instance, speak to your coding team within your trust. They're probably going to be the best source of information. The classification service is sort of the group that would probably provide the most information, but they, by their own admission, are not very good at keeping their own website up to date.
Yeah, I would say contact your own coders, because every organization codes in a slightly different way in terms of what's accepted, what's not accepted, what sources they use. So for example, in my organization, we code exclusively from electronic records, even though we have a hybrid system of notes and electronic records. So it is worth speaking to your coding teams to see how the system works in your own organizations. Thank you very much, Sam. So if we come back in 10 minutes, so roughly at 20 past or just after 20 past 3, to talk on primary care finance. and will be followed straight after that by understanding budgets and spreadsheets, and then I'll be finishing off the day with business cases. So we'll see you all in about 7 or 8 minutes. Have a stretch for your legs and grab a drink. Thank you very much, and apologise for running late. As I said, I know people are going to be dipping in and out, so it's going to be recorded. So hopefully we'll catch up sometime on my session and see how we go. Thank you very much.
Thank you very much. Yeah, I will try my best to get some time back for you all then. But if I share my screen, hopefully that's come through okay.
Yeah.
Cool, yeah. Brilliant. Thank you very much. So yeah, like I said, I lead on primary care finance at Suffolk and North East Essex ICB. So the plan for today is to kind of give an overview of primary care finance and the funding streams that are available to GP practices and PCNs. So I'm going to look to cover various funding streams that are available. So you've got your core contracts, a DDRB uplift, which it's fairly hot off the press, qualities and outcome framework, often known as QOF, enhanced services, excuse me, premises, primary care networks, the additional roles reimbursement scheme, and then any other payments. So if I work through each of them, and happy to take questions at the end. So about half of the income that GP practices receive will be via their core contract. These are payments made on a weighted patient basis. So there are 3 different types of GP contracts. You have a general medical services contract, so GMS. This is the main national standard GP contract. I think it accounts for about 70% of all GP contracts in the country. It's the core contract negotiated every year by NHS England and the BMA, and kind of gives core guidance and requirements and specifications as to what the GP practice has to deliver within that contract. You then have a personal medical services contract, which is similar to the GMS contract. It's kind of like a GMS plus almost. It is it's slightly more flexible. It's negotiated locally by your commissioner and the GP practices. And it allows for a slightly more local determination. So if there was, for example, a key metric or element of primary care that you felt needed focus within your commissioning area, you can include that within the contract, and then that provider would have to provide that service in able to fulfill that requirement. By default, the rate that is paid to these contracts inevitably is higher than the global sum because the ask on those providers is more than the standard GP contract. And then you have an APMS contract, which is an alternative provider of medical services. This is the most flexible of all 3 contracts. However, it only accounts for about 2% of GP contracts within the UK. It allows contracts to be held by organisations other than GP practices or partners, excuse me. So, for example, a private company can hold an APMS contract and deliver primary care services within that patch. So, for all of these contracts, they are paid on a payment per weighted patient. The 23-24 rate is £102.28 per weighted patient. And when I say weighted patient, that is the practice list size multiplied by various factors, including age and gender. I think it's called the Carr-Hill formula, which kicks out a weighted patient list size, and then that is your rate at which you're paid. So, for example, if you have a very young population within your GP list size area, you will invariably, your actual list size and your weighted list size will be very similar. However, if you have a more elderly population and more rural, your weighted list size will be greater, and invariably you'll receive a higher income for that purpose because it is felt that those patients require more medical attention and more appointments and a greater care package. The payment is paid or set up at the start of the year based on your list size as at the 1st of April. However, that is adjusted every quarter for list size adjustments. So list sizes change, people leave practices, people join practices, and every quarter an adjustment is made to your core contract payment, which the GP practice receives. So if you lose some patients and your list size reduces, you will have a slight clawback, and vice versa. If you gain patients, your core contract payment will increase. There are a couple of opt-out services within that core contract that the GP practices can opt out of. The main one is out of hours. So as a result, there's a deduction made against your list size of £4.86 per weighted patient, which equates to about £4.75, 4.75%. Now, it is the responsibility of the commissioner in that case when they opt out, which invariably most GP practices do, to provide an out-of-hours service within that area. So they are the core contract payments. Like I said, last month, in the DDRB, so Doctors and Dentists Remuneration Board, agreed a pay uplift for salaried GPs and staff, which equated to a £2.45 increase per weighted patient for all of those GP contracts. So that rate that was £102 was increased by £2.45 to become £104.73. GP practice should be receiving that backdated payment to April within their November income, and that will be their new rate going forward. And there's also, as a result, the out of hours opt-out also increased by 11 pence. So these figures that is now £104.73, they're negotiated every year with the BMA and NHS England, depending what factors are included in the contract and what they feel the new focus areas are each financial year. And at that point, that global sum number is released every year by NHS England as the basis for the core contract payments, and then it's up to local commissioners to decide your PMS and your APMS rates, which, like I say, invariably are higher than that because their contract includes more requirements and different metrics upon which they're measured. And then there's various other areas within the GP contracts that they can earn income from and how they're paid. The Quality and Outcomes Framework, so QOF, accounts for 10% of a practice income on an annual basis. So, some fairly substantial numbers attached to QOF, which again is set out in the national contract. Is key metrics that the NHS England want focused on, and the GP practices can earn payments based on their achievement against certain metrics and certain codes. So it is a points-based quality incentive scheme for practices. There's a various number of points available. This year it's 635, and the value per point is £213.43. So like I said, some very substantial numbers flowing through QOF. It's a complicated metric and how it's calculated. It's a value per weighted patient per practice, but then the practice list size are adjusted for national average list sizes, and then also prevalence of disease. So I think I had this previous presentation referred to it as a sausage machine, and that is very much what QOF is. The practice codes on their clinical systems that are collected nationally, centrally, and calculated against various metrics and prevalence, and it kicks out a QOF achievement score and percentage achievement against those metrics. So like I said, the metrics available, they're asked to focus on vaccinations and immunisations, AF, diabetes, asthma, and mental health. And then there's a public health domain as well, aligned to public health requirements for things like blood pressure checks, obesity, smoking, stop smoking services, and then a quality improvement domain as well. So because this is a substantial number, the practices receive a QOF aspiration payment every month, which equates to 70% of what they earned last year on an equal 12 basis. And then when all the coding is completed and submitted, the payment for achievement is paid every June in the following financial year. So because that number is quite large, they give an aspiration payment throughout the year, and then a top-up achievement payment is made in the June of the following financial year. Another funding stream available to practices is enhanced services. So there are some direct enhanced services which are linked to the core contracts, including LD health checks, minor surgery, and primary care network participation. I'll come on to that in a moment, but they are core contract requirements. So they have to sign up to these schemes and then are paid on a on a basis in which they provide them. So the LD health checks, they're paid at a rate per check they do, and then reimbursed on a monthly or quarterly basis. And then on top of that, there's also local enhanced services, which commissioners can agree locally, and it's up to local determination and budgets. But they are areas which, again, the local commissioners feel are a requirement within their area that need focus. They can include a range of things. I think most things could be a LES, if agreed with the practices and LMCs. For example, just a couple that we have in Suffolk, we've got phlebotomy, minor injury, near patient testing, and on top of that, there's DVT, safeguarding, phlebotomy, and care home checks. So these are all specifications that are agreed and drawn up by the commissioner. There are key metrics that have to be achieved and attained by the practices against those, and then there are payments, again, either an at cost and volume rate or a fixed payment, depending. For example, the care home one is a fixed payment. They just have to align how many care home beds they support within their usual working and GP practices. Another element for which GP practices are reimbursed by the commissioners are for their premises. So they are reimbursed their non-domestic rates from the local council. So in essence, these are their council taxes. So they're reimbursed in full by the commissioner. Water rates are reimbursed. Note that electricity and gas are not reimbursed. So we reimburse the rates and the water rates. And then obviously the big premises income is for the rent. There are various types of rent that are paid out to GP practices. You have notional rent. So these are when the GP partners own the building from which they operate. So essentially what we're reimbursing in those cases are the mortgage rates on a monthly basis. And then you have actual rent. So this is the most common type we have within the primary care world. So this is for when the GP practices lease their properties. So we just reimburse the rent in full. So all of these processes done by a district valuer who inform us of the rates we have to pay as commissioners back out to the GP practices. And there's a section of GP practices and premises which are owned by NHS Property Services or community health partnerships. And again, these rates are agreed and reimbursed alongside the district valuers that we employ to do these checks in the district valuers. There are certain rules around what can be reimbursed and what can't. The GP practice, it only has to be GMS or PMS space that's reimbursed. So there are certain rules around if they're using a room for storage, we wouldn't pay that, for example. That would be taken off the rent value that we reimburse. A couple of years old now, but primary care networks, or PCNs as they're known, were introduced a couple of years ago. These are a group of GP practices, usually and ideally within a similar geography, that together have list sizes or serve around 25 to 50,000 patients. So every practice that becomes part of a PCN receives a participation payment of £1.76 per weighted patient. And there are various other payments which I'll talk through in a moment, but in essence the theory behind primary care networks and PCNs was to get a joint way of working across practices, to share best practice. We're all aware of the pressures on primary care, so it's about sharing staff, sharing space, and just working together in a best practice way possible to serve the needs of their patients. So there's various payments that are associated with primary care networks. These are paid to the PCNs, not the GP practices. So they are separate entities and will have different managers, for example, and different bank accounts. So these are completely separate entities, but they work together as a group of GP practices. So they get paid for a clinical director. So each PCN has to have a clinical director, and they get reimbursed to cover a portion of those costs. That payment is not the full amount. So that's just under 73p per patient. There's a core PCN payment of £1.50 per patient. This is, in essence, they kind of use it to help to essentially run their PCN and all the costs associated with that, and any schemes they want to get up and running, as a group, they can use that payment. And then they have enhanced access scheme, which is the big earner. So that's £7.57 per adjusted patient. So this is, in essence, they have to provide GP services between 6:30 and 8 p.m. every evening, Monday to Friday, and 9 a.m. to 5 p.m. every Saturday. So this is a big drive under the primary care access plan. The GP practices can provide those services themselves, or they can subcontract, but the money goes to the PCN for that service to be provided. There's also an investment and impact fund, IAF, so all the acronyms within PCNs. So this creates 95p per patient per year, and this again is similar to QOF, so it's a points basis, performance-based metric, and that's paid out annually. But the PCN works together on this, so it's not the individual practices, it's the PCN that has to submit this return and perform against the metrics, which include addressing health inequalities and access, cancer targets, and again LD health checks. They also get paid £120 per care home bed per year. This is associated with additional costs of having those care home patients within their list size, care home visits that may take place, and the additional costs around those. Then they get paid a management and leadership fee. Again, that's a PCN manager, so that's different to clinical director. This is PCN manager. And then a capacity and access payment, which was implemented 2 years ago now to allow the PCNs to improve their patient experience, the ease of access across the PCN for their patients, demand management and recording processes. So again, it's a fairly substantial list of schemes and funding streams available to them, and some fairly big numbers attached to those if you're on paid on a per patient basis. The big scheme within primary care networks as well was a workforce reimbursement known as additional roles reimbursement scheme, so known as ARS. This was a big driver of the PCNs coming together and to try and tackle the lack of GPs that are available within primary care and the declining number of GPs. So this is a range of roles that the PCN can employ, and again they can use these roles across, if there's 4 practices within a PCN, these ARS roles will work across all of those practices but be employed by the primary care network. The PCN has to submit data to a national portal around how many hours they've worked, what banding they are within Agenda for Change, and then the commissioner reimburses those roles on a monthly basis directly to the PCNs. So as you can see of the list, there are a range of roles that are now employed within PCNs and can be used by the GP practices within those PCNs to try and tackle session coverage, and trying to get people to the right clinical staff. This should allow GP time to be freed up to deal with the more complicated patients and really care navigate those patients from the first contact they have with a GP practice or a PCN. And then, so they're kind of your core ones and your main ones that are paid to all GP practices and PCNs. And then there are various other payments which are made throughout the year by commissioners to GP practices, including locum costs. So the ICBs will reimburse locum costs to cover maternity, paternity and sickness. So we do not reimburse locum costs for, if a GP leaves and they just need to cover some sessions. These are very specifically for maternity and paternity and sickness. We reimburse syringes and needles, and then GPIT, including schemes like cloud-based telephony. You may have heard things like Ask My GP, online consultation, those sorts of technology-driven schemes, which are, again, with the aim of trying to free up GP time and GP sessions. GP practices are also reimbursed for prescribing fees and drug costs via the NHS BSA, so EPACT or EPACT2 as it is now known. We also reimburse CQC fees, so GP practices pay a amount every year for CQC fees, so they are reimbursed. And there's a range of commission services still sitting with the NHS England currently, which they are also reimbursed for immunisation and vaccination programmes. That's your flu and obviously more recently COVID vaccination. So they get paid for the actual drugs and injections alongside that and the on costs associated. GP practices can also be training practices. So again, a real drive from national training hubs to try and support GPs and get GPs back to work and return to work schemes. So if you're a training practice, there's also a top-up payment that is made. And then they're also reimbursed for public health services, contraceptive services, stop smoking, drug misuse services included as well. So I appreciate there's a lot of information on those slides, and it covers a lot of areas, but it's just to try and break down the funding schemes that are available to GP practices and now PCNs. And yeah, so a lot of it is driven by national guidance, including the core contract and the enhanced services, which can be paid, and those rates are fixed. And then there's more commissioner flexibility around local enhanced services and those PMS and APMS contracts. But yeah, there's a whole raft of reimbursements. But appreciate that was a whistle-stop tour, but happy to take any questions anyone may have.
Thanks, Jessica. That's great. It was a whistle-stop tour, and it was really good. Oh, there's some questions coming in.
Yeah, I'm just thinking.
Do you have any sense of whether this funding model will continue next financial year, particularly the ARS roles?
Yeah, so that is the hot topic at the moment. So it has been mooted that currently the R's allocation company comes to the ICBs and then we reimburse on a, as they submit to the portal. It is next year that we're expecting it to go into the baseline. So again, no confirmed details on this, but the expectation is that that core contract number will increase, and then the GP practices will just pay, or sorry, the PCNs will pay those R's staff just through their normal income streams. But like I said, that is not yet confirmed, and I think they're still in the process of how those allocations will be shared out to PCNs on what basis.
Great, thank you. Any other questions? And thank you very much for making up some time, because
no problem. I appreciate it's getting towards the end of the day, so you're happy to.
It is, yeah. So moving swiftly on, we've got the team from East Lancashire Hospitals NHS Trust. We've got Amina Yaqub and Declan Byram, who are going to talk about giving an overview of how budgets and spreadsheets work and how you can make best use of them. So over to you guys. Thank you very much for attending today and joining us.
Thank you very much. So I'll start off and then I'll hand over to Declan and then he'll hand back to me. So my name is Amina Yaqub. I am the Assistant Director of Finance for Benefits at East Lancs, and we have Dec, who's our Deputy Divisional Finance Manager. I think Dec's having some, there we go. So we're going to talk through, it's okay. We're going to talk through some understanding budgets, and I just thought I'd give you a little bit of context about what we do as an organisation. So we are based in Blackburn. We cover 5 hospital sites and various community sites, and we employ over 8,000 staff. We treat around 700,000 patients a year, and our annual income is circa 740 million. So we're quite a vast organisation, and we predominantly specialise. We have a range of specialist services, such as head and neck services and urological cancer. So we're quite widespread, and we have recently acquired some GP practices. So we are also in the primary care field. Our finance department is quite typical to other finance departments in the NHS. So what you'll tend to find in acute organisations is that we will have a financial management team, which covers and focuses on areas such as providing information that trust needs to understand its cost base and drivers in its income and expenditure. Most of them tend to have an income and costing team, and we do also, who look at SLAM monitoring and contracting, and they're the main conduit for our contract negotiations with commissioners, and they predominantly oversee costing and efficiency also.
all organisations have a financial accounts team, predominantly because of the requirements around our statutory duties to provide information around our finances, but they are also there enlarged to put a level of financial control and cash management from a revenue and capital income and expenditure perspective. Our trust and many other trusts have recently introduced benefits teams. So I lead the benefit realisation team at East Lancs, where we focus on reviewing investment decisions predominantly over £1 million and looking back at them to see if they've given us what we needed as an organisation, but also if there's any key lessons that we needed to learn from it. Moving on, if we look at our how we're aligned to future focus finance, we have very similar values, and we use these values to base our Finance Employee of the Month award too, because the key thing for us is to remain focused on respecting the individual, acting with integrity, and to promote positive change within our organisations. And we very much believe that finance can be a conduit to that. So when we think about budgets and understanding budgets, it's really important to recognise the integral role that our teams play in hospitals and how we can move that forward. So I'm going to pass over to Declan, who's going to talk about what a budget is and how it works in the organisation.
Yeah, so as Amina just mentioned, what is a budget and how does it all work? So a budget is a plan of what you intend to do in each period, expressed in financial terms. And this can be as short or as long a period as you want, but in NHS finance, we usually go off monthly, quarterly and annually. And we all budget already with our salaries, and we'll come on to how we budget later on in the session. But in short, it's how much you plan to spend on staffing and all of the non-pay costs, such as contracts, consumables, drugs, insurance, and many more. We have manpower considerations, such as safer staffing onwards, which we call professional judgment. The amount of activity and pressures that we have, and along with how much income that we plan to receive and what resources will be available. So why do we need to set a budget in the first place? So the NHS, like all the other organisations and businesses, has limited resources, and we must manage taxpayers' money as efficiently as possible. So a critical part is organisational planning, so that the trust can identify its expenditure against its expected income for the period. And in order to control that expenditure, we need to ensure that the trust gets value for money. We have authorisation processes, like a budget order will ensure costs incurred are valid by authorising expenditure to their budget. And we have performance and accountability, where budgets are critical to organisational success. So some examples of how we set the budgets in our organisation. The contracted round for 2023-24 has been simplified, and to an extent the trust remains on block contracts for this financial year as opposed to activity-based. Other income streams are looked at, such as education funding, overseas visitors and R&D. All funded staffing posts are recosted each year, and this is a 2.1% added for pay award, but we in fact receive a 5% added pay award along with a non-consolidated back payment. Any foreseen pressures and developments are collated by divisional finance managers. Non-pay inflation for this year were funded at 4%, apart from drugs, which were funded at 1.3%, and the trust liability insurance is received. And then after all that, our waste reduction programme percentage, so that's our savings target, is calculated. So can a budget be changed mid-year? So ordinarily no. NHS England will always plan to monitor an organisation against its plan. However, some organisations do change local service line plans in year without changing the bottom line. And there are occasions where something sizable happens mid-year, which warrants a change in the budget, such as a loss of service. Capital and revenue budgets. So the NHS has a capital budget of £7.9 billion. And in order to allocate something to capital, it has to last for over 1 year and cost over £5,000. Trust has set a capital resource limit by NHS England, which we can't exceed without permission. And we also have a £153 billion revenue budget, which are our day-to-day running costs, such as salaries, drugs, consumables, etc. And these relate to a period of less than 1 year. So the total NHS budget for this financial year is £160.9 billion. And I'll hand you back over to Amina that will talk to you about how we manage them budgets.
Thanks, Dec. So when it comes to pure financial management of the budgets, ultimately that's done through our financial management team, and it's about planning and monitoring those budgets to support accurate and effective financial reporting. We rely on the budgets and the work that the financial management team does to be able to support the delivery of our forecast outturn each year and to support the achievement of our waste reduction schemes. So ultimately, we need it to be robust and effective. What we have to recognise is that it's not done in isolation, so it has to be done with the organisation, and we need to make sure that regular budget meetings are set up between our divisional finance teams and service managers to ensure that budgets are planned and monitored effectively. And the team needs to be very much embedded in the services, so we don't like to see a situation where our sort of DFMs are very much isolated from the goings on of the hospitals and what we do, because ultimately that's where pressures come about and we're not cited on them. So it's very much a process that involves multidisciplinary teams working together for us to be able to report effectively. So when we talk about our budget holders and the responsibility that they have in our organisations, a key part of that is for them to engage with finance teams to ensure that we have accurate budgets in the first place, because there's nothing worse than starting out a year and within month one you're showing a variation to a plan and saying that actually our plan was wrong, or there was something that we didn't baseline correctly. It sets the wrong tone for the rest of the year. So that's really important for us, and we make sure that budgets are in line with our SFIs and that we manage and contribute to the NHS cost improvement programme as individual organisations, because we have a sort of responsibility to do that. We encourage everyone to reach out for support across our organisation. You know, you should know your DFMs, you should be in touch with them, and you should engage with them to make sure that that flow of information remains consistent between the departments. I just want to talk a little bit about the NHS cost improvement programme, named a varying of things, often called the QUIP programme, the WRP programme, but in essence it's about when we look at how we can drive efficiency to reduce expenditure, and often it's a year-on-year saving that we're looking for. So we're looking for a recurrent cost-based reduction. Now that's our standard financial instrument. So it's basically tools that are put in place for us. Our SFIs are there to make sure they're sort of standard across the organisations, and they're there to make sure that we're in line with them and we're meeting the requirements of them. But in essence, in 23-24, the NHS had a collective efficiency target of 5.6 billion. Now that's nearly 5% of our turnover. For us as an organisation, ours is actually £55 million, which is 7% of our turnover. Now in the history of NHS efficiencies, we've never quite seen them be that high. It's a massive target, and it reflects how financially pressured our organisations are and operationally pressured. So a large part of the work streams that need to underpin our cost improvement programme focus on us understanding information and understanding data to help us support efficiency across the piece. I mean, last year we delivered 2.5% as the NHS from an efficiency perspective. So it's quite a leap and quite an aspirational plan that we have in place for this financial year. So what can we say the future holds for the NHS and for finance in particular? We know that there's an increasing cost base when it comes to the NHS. I think that's largely driven by a higher level of acuity and dependency, fueled by obviously the pandemic and an ageing population. And we're still very much recovering from the pandemic. Declan alluded to our block contract arrangement, and unfortunately block contract arrangements in the situation that we're in is that they can be quite stifling, because actually what we find is our activity has gone up exponentially, and our income doesn't actually reflect the work that we're doing in the hospitals, certainly. So it's an interesting place that we find ourselves in. and it's further exacerbated by the cost of living crisis and what we know around a 40-year high in inflation. So all in all, it's proving to be quite a difficult landscape for us to operate in financially, but there are systematic changes that have come into place to support some of these pressures in the NHS, and I guess it's how we collectively manage some of them. Some of that is through what we've seen in a change in the health and care landscape collectively. Just onto the next slide, please, Dec, where what we've seen is a creation of the ICBs and more trusts merging through sort of governed group structures. These are in part for us to be able to drive a level of efficiency just purely through headcount perspective, but also to reduce variation in service provision. So where we see collaboration working more effectively for us is to allow system working and standardized practice to become the norm, and for us to be looking continuously at our organisation to say, how can we adopt best practice and what is that best practice for our patient cohorts. So where we're doing some of that more effectively is to work across the Lancashire and South Cumbria cohorts of providers to say, how can we collectively come together and collaborate, because we know that our patient cohort is actually quite similar too. And we're also looking at ways that we can use data to support that change. So where we've got information around model hospital and GIRF, how we use that information and use what we know around our digital journey to support some of our future direction across the patch, not just within our organisation. But ultimately, I guess the key point I would like you to take away from our presentation is to say that although we are in a very challenged financial environment, there are masses of opportunity in this environment, and it's all about how we work as finance teams across our organisations and across our clinical teams to drive some of them changes that will deliver effectively for us. And we are open to questions, both of us.
Any questions? Thank you very much. Stunned silence, or is it just the end of the
Stunned them
day?
into silence, I believe, at 4 o'clock.
Yeah. Okay. Okay, well, thank you very much for taking the time to come along and helping us today.
Thank you, no problem.
I know a lot of people have got to drop off now. I'm going to be talking next about business cases to the remaining few that are not dropping off. But thank you very much, both Declan and Amina, for your help today. I was just seeing if anybody was putting any last minute questions in, but no, it's fine. Thank you. So finally, I've got the task of talking about business cases. I'm going to share my screen. As I said, I know people are going to be dropping off. That's fine. I have no problems with that. What I am going to be doing is, once things stop pinging, is talking about business cases. Now, again, as with everything today, this is very much an overview. Every organisation has a slightly different process for business cases. This is the public sector preferred way of doing business cases, and whilst your individual organisation's templates may have slightly different wordings or slightly different concepts, the broad ideas are still the same, and the tips are hopefully will still be the same. So a business case is utilise idea. Most people think when they think of a business case, it's a way of getting something you want. So whether it's an extra clinic, whether it's more equipment, whether it's more resource, so staffing, anything like that, it's a way of getting more things. But actually, there's two things to the business case. Yes, it is. It's a way of prioritizing what needs to be funded when, in a structured way. But it's also a way of establishing or working out decision-making process that gets you to the solution. And what I mean by that is that essentially too many business cases come up with a solution without going through the right processes. So to start a business case, you need a problem, you need a question that needs to be solved. Okay, and that is probably the biggest reason why business cases fail. Business cases fail because people come in with a prescribed and definite solution. This is what I want. This is why I'm going to get it, without necessarily having the thought behind it, the kind of research and the data and the narrative and the argument behind it. And so what we're going to try and do today is give you an idea of structuring it and give you a way of delivering that narrative in an appropriate way. So it's before you embark on delivering a business case, you need to really understand the process within your organization. And a little bit, you need to know who you're targeting when you're trying to do the business case. So is it an internal business case that your organization needs to fund? Is it something the commissioners need to fund? Is it something that an external body needs to fund? Is it a bid for money or resource from, as I said earlier, the NHS resolution has some patient safety money. There may be some education money. There may be, depending on the type of business case you're trying to put forward or application trying to put forward, you need to understand what it is they're looking for and the process behind it. Within organizations, they often have, depending on the amount, the size of the business case, so in terms of the monetary value of the business case, will determine how many hurdles or how many committees and processes need to approve it before it gets formally accepted and approved. So, if it's up to a certain value, and every organisation will have slightly different, and they're often in the standing financial instructions, so in the SFIs, they will kind of give you what the process is within your organisation. So some of them you need X number of tenders, or if you're buying kit, you might need 2 or 3 tenders. If it's above a certain value, then you get into the procurement regulations and you have to put in a formal procurement process. But what needs to go into the business case? Well, generally it's the who, what, where, when, why. All those kind of all the questions need to be answered, essentially, in a business case. So what we're going to use is something called the 5-case model. As I said, it is the designated preferred way of delivering a business case in the public sector. It has been for the past at least 20-something years. As I said, most organizations have a variation of this of some sort in the questions they ask, and they want to get this information out, whether it's named this way or not. And then there are 5 cases, and it's 5 areas: the strategic case, which is your rationale for it; the economic case; the commercial case; the financial case; and the management case. And I'm going to try and in the half an hour or so we've got left, I'm going to try and cover this to some degree. But this is it is never a one person or a one department area. This is an area where you need to get involvement from multiple different people to help you write a business case for it to be truly to get a good one, essentially. The aims of a business case. So the first kind of hurdles you've got to get is it has to be desirable, has to be viable, and has to be achievable. I'd love to go in right now and go, I'd like to build a whole new hospital. It's desirable, yes. It's probably not viable or achievable because of the costs we're looking at. I'd like to merge all my 3 sites onto one site, but that's not viable or achievable. There's no space. There's lots of other barriers to that. So it has to initially be all those things. There are 2 drivers of a business case, and that's to solve a problem or an issue that you have, and that is the main driver, and that should be the driving force of the business case, not the solution, the problem. Or you want to improve quality, and that can be an important driver. It is often a lesser driver than solving the problem, because by solving a problem, you're showing that you are by having a problem or showing that there is a problem, you're showing that your quality is poor and you need to improve. Whereas improving quality is just building on what you've already got. But depending on what it is and the arguments behind it, they're both good drivers of a business case. In the past, increasing income has also been a driver, but that's less of a it's not found to be that useful in the current climates. You can still use it, but your focus should be improving quality or solving a problem. And ultimately, and I'm going to repeat this, you have to show that improvement in quality, and ideally in one or multiple domains of clinical outcome, patient experience, and patient safety, is worth the costs, both the revenue and capital costs. That has to be the underlying drive. You have to show that in your business case. If you don't show that, then it's a very easy one to dismiss. So that has to really be shown in your business case. Now, I won't go on to this in too much detail because it's already been mentioned in the previous talk. So I'm going to give you this slide at the end, which kind of summarizes it all. But there are, depending on the size of the business case, there are different steps, because what you don't want to do is do a lot of work to find out that actually it's a non-starter. And so for the big business case, the high value business cases, there tend to be 3 steps. You get the strategic outline case, where you kind of get you kind of establish your case for change and your potential potential solutions, and you kind of pick your solution, and then you move on from that, and there's various steps until the full business case is only ever really written once it's essentially been approved, and you're just dotting the I's and crossing the T's before you actually contract it out. For most people, the business cases is much more of a smaller document because of the size that we're talking about, and it's much more manageable within a few people doing it, and doesn't have to go through all those stages, but though there may be a number of steps and a number of committees that need to go through. So that's the kind of background to it. So we're going to get into the nitty-gritty now of writing a business case. Strategic case. This is where you put your context in. This is where you have to look at your organizational aims. So whatever your kind of organization's plans are, whatever its ambitions are, and you have to show how your business case fits into that. Okay, all the ideals of your business case fits into that. What is the problem that is trying to solve, and how that is a problem in terms of the organizational is wider aims and ambitions. Okay, so that's key, because that's an easy one to make it a higher priority. And then you've got to go into the detail, and this is where really is where a business case can pass or fail based on this bit. And this is the case for change. So you've got to show why there needs to be a change, and you need the data to back it up. Okay. Now that can come from benchmarking, so you can compare yourselves with other hospitals, and that can be done in model hospital. That can be done in there's lots of metrics out there that you can use to build your case for change. GIRFT is the Getting It Right First Time program, which again is another way of benchmarking. It has certain criteria and certain things that you should be aiming for, and again that's a good motivation to achieve to back up your business case. You have your CQC reports, which again are very strong motivators to deliver your business case. And then you've got the NICE recommendations or Royal College recommendations, which are useful, but they may not on their own, depending on what they are, drive your business case that far, because there are so many NICE recommendations, there's so many Royal College recommendations. Whilst if you have a little bit of surplus money or a pot of money that's been underused, then that might be enough of a driver, but often it doesn't always be that, it's not always the main driver. Mortality reviews, root case analysis can also be useful as well. So to give you an idea of how you can use that, so desflurane is a gas that's really bad for the environment. There was a national driver to get rid of it. This is data taken from Model Hospital from last year or a couple of years ago, where my hospital, which is the blue line, showed we were very high users of desflurane, and I used this to put together a business case to buy more pumps, so bits of equipment that would not replace these, to encourage people not to use desflurane, okay, as an alternative means. So you can use this and say, look, we are a really high user. We need to try and shift people away from using it. One of the ways we can do that is if we have enough of this other pump, this other resource or other bit of kit that can do that. So that was a good way of doing that. Another one is this is again, as I said, a lot of mine are surgical or anaesthetics or theatre based because of my specialty, but this showed that if we looked at length of stay for an emergency, so if you have an appendicitis and you have your appendix out, the kind of length of stay target is less than 2 days, and we are very poor on that. So we're the black, this is a couple of years old, but we're the black line there. And when you look at the data a bit further, you can go, actually, that's not because we have particularly poor outcomes or anything else other than the fact that a lot of our patients wait 2 days before they have their operation because we haven't got enough emergency theatre capacity. And we use that to increase our emergency theatre capacity. Okay, so you can use the data and show the problem to drive your business case forward. Okay. So within your strategic case, you're also looking at your, what are the existing arrangements? Okay, so what is it that you currently have set up? What is your business needs? So what by that mean is like what are the demands on you? What are your current demands and what are your future demands? So for example, when we're planning our maternity services, we look at our current kind of status in terms of how many deliveries we have, our epidural rates, our cesarean section rates, anything like that. But also we have to factor in the fact that, they are increasing. They have been increasing for several years in the past, and they are likely to increase in the future. And as people get older and we get higher complexity levels, our needs in terms of intervention are going to be higher. We also, in our hospital, have recently taken on, some regional work in terms of maternity. So we'd have to factor that in terms of how is it going to affect our resources and our complexity and what we actually, the activity we're going to be doing if we want to increase our resources or increase our staffing or anything like that. Okay, so we have to look at both the current and the future needs. You look at your potential scope, and that kind of links into your spending objectives. So your potential scope is what are you going to be able to do? Now, I'd love to be able to build a whole new theatre complex to solve my emergency capacity problem, but that's not within my remit. It's not within the scope of any business case I'm going to be able to write because it's not realistic. And so what my spending objectives are primarily in regard to staffing. We can't improve the infrastructure as such, but we're going to be looking at staffing. And that kind of links into constraints and dependencies. What's going to constrain the scope of your business case? If you want to increase your service to deliver more outpatient clinics or more outpatient clinics is a good example. The biggest constraint in developing of services is estates. So, when we wanted to increase our high-risk anaesthetic clinics, our biggest limitation was actually rooms available to do them in. we couldn't find suitable rooms to do them in, and so that really limits what you can do in terms of your in terms of expansion. You know, we would love to be able to have a day a week and have a single stop pre-assessment process where you see the nurses, see the anaesthetists, but we haven't got an estate facility big enough to can't cope with that. Okay, so that's your constraints. Your dependencies are if another business case depends on your business case or they're interlinked. An example of that would be, you know, Oxford, when they built a kind of a day surgery unit for orthopedics. And so they had a linked business case to supply radiographers and X-ray equipment, because actually a lot of orthopedic surgery requires X-ray equipment and the radiographers to use it, and maybe even a radiologist to interpret it. So the business case for one is dependent on the other being successful. So, you know, they're directly interlinked. So you've got to highlight that as well, saying that, you know, there's no point in building this whole new unit if you haven't got the right appropriate staffing. Okay, sometimes they can be combined into one business case. Sometimes they're separate business cases because they have different. You know, one would be a capital budget one, looking at coming from NHS England or the ICB, and the other one's an internal start, increasing your staffing based on from within your organisation. Okay, so that's your constraints and dependencies, benefits and risks. So you have benefits, which are obviously the positives. You have disbenefits, which are the negatives or potentials negatives, and you really need to mitigate against them. So in the past, I've done business case workshops where people have pitched business case ideas and we've kind of worked through them. And a radiologist came to me and presented an idea for breast screening program. And rather than the traditional mammogram, they've got a new way of you inject some sort of something. You put a drip in and you inject something which is a higher quality and more specific, or maybe better sensitive, more accurate, essentially, better at picking up breast cancers. Is ultimately what it is. But when I asked the question, okay, so that's going to take longer, and therefore, if you kept the same amount of sessions per day, then you are going to have fewer numbers of people going through it, which will affect your 2-week wait and all your implications on that. So that means that people may have to wait longer for their breast screening. And so actually, in order to mitigate that disbenefit or disadvantage, you then have to make sure you increase the number of sessions you're asking for to counteract. So you're seeing the same number of patients. Okay, and factor that when you're costing it. And the risks are about often related to implementation, or what happens if things don't go quite to plan. What are the risks of something untoward happening? Okay, so and then when you're looking at risks, you look at ways to mitigate those risks as best as possible, and you have to document those as well. Okay. So when we're looking at existing and future needs, one of the ways you can do that is by looking at demand and capacity modelling. So this is something for radiology, where they look at the number of each of these modalities, which are different radiology modalities, imaging modalities that they performed each year. So they looked at 2017-18, they looked at 2018-19, and they noticed there was a 5% increase. And if they're conservative and they kind of factored in a 2% increase, then this is what they expect for the next year. Okay, so you kind of have you almost have a range of conservative estimates and a less conservative or ambitious estimate of what your activity might be, and then you look at your demand to compensate for that. So you look at unbundled additional lists and the number of patients, and you can look at how many lists per year that would kind of involve. Depending on the payment system at the time, you may or may not generate an additional income. So you can look at your unbundled tariff costs for this particular type of modelling, but I've left that in grey because it depends on the exact type of payment system that's then in action, but also the exact nature of the business case. But essentially, you look at your demand and capacity modelling and work out what is it that you need or what you're predicting to need in the future. So there's no point necessarily basing it on the current demand, because that changes every year. We know that healthcare is becoming more demanding as the years go on. So you've got to predict it and future-proof it a degree, because you can't keep putting the same business case in every year and ask people money. They'll think you haven't thought this through. You want to look at least 3 years, if not 5 years into the future, and kind of plan for that and say, this is what we're going to need over the next 5 years. You may not need all the money now, but you want a commitment that this is what that's what's going to happen. So that is probably the biggest. So the strategic case is probably the most important bit. It is the absolute key thing that's going to determine how well your business case is going to be perceived, okay, and how much of a priority it is. The next bit is more about your solution. Okay, so you have to come up with a list of potential solutions to your problem, and you start with a long list. So, and again, the biggest problem I see with business cases, when you look at business cases, is people come up with one solution, and then what then happens is people who are, because most people who are looking at the business cases are not the experts in the field that you people, the people that are writing the business cases are. So the people that are writing the business cases know the area in detail. So whether it's the clinicians, whether it's the operations teams, you know the ins and outs of what will work and what won't work. But the people looking at them won't. They'll go, why don't you try this? Why don't you try this? But if you, in your economic case or in your kind of shortlisting, you've kind of gone, okay, this is what we need. We could do all these things, but this doesn't work because of this reason. This doesn't work because of this reason. This doesn't work because of this reason. You can be shown that you've thought about this in a kind of systematic and logical way. So you start with a long list. You have your assessment criteria. Now that can vary. There's no set assessment criteria, but you have to then have your critical success factors. So your, it's like in job descriptions. You have your desire, you have your essential, which is your key things that you have to get, and you have your desirable, which is the things you would like. And you can weight your assessment criteria in the same ways when you doing a job description or you're evaluating something. You kind of weight it and go, well, I'm going to weight this higher than that, and these are the key things that I want. And then you get to your shortlisting, okay? And you really need to, when you get to your shortlisting, you need at least you need 3 really options, and it must include a do nothing or a minimum doing minimum option. Because once you've done that, then you do on those kind of 3 options. You do your kind of economic appraisal and your cost appraisal. Now, this is where you have to then get finance involved, because you have to then look at your qualitative benefits, and there's terms like net present value and things like that, which are very important to look at. How long, over what kind of period of time, you need to have this impact for. Okay, so is it worth the investment? What kind of period of times are we talking about? And you have these kind of taking into fact various types of depreciation. You get depreciation and amortization, which are essentially different ways of justifying the fact that things go down in price and inflation kicks in. Okay, but essentially look at your quality benefits and your cost appraisal. But this is where I said, for the various aspects of this, you need finance people's input, because they have templates for all of that kind of stuff. So it's a team, it's a group effort. But as I said, the shortlisting is really critical, and then you can get procurement and finance to help you with the next bits. But people often ask me, how do you come up with long lists and a short list, because they can't think in a way of doing it. So one of the ways of doing an options appraisal is to think of it in this way, okay? And whatever it is, you kind of look at it in this kind of various different concepts of scope, service solution, service delivery, implementation. Now, because everybody comes from different specialities, I'm going to use well, I used to use HS2, but that's kind of gone a bit out of the way. But I'm going to use it as an example anyway. So the problem we're trying to solve is increasing railway capacity between London and the rest of the country. Okay, so between London and Birmingham, the northeast and the northwest. Okay, so your scope, what it is, so it is the minimum is to improve the connection between London and Birmingham. Okay, because that was found to be the main area of where there's not enough, the problems there. And then you look at the intermediate will be to between London, Birmingham, and the northwest, and then the maximum will be to the northwest and then up to Leeds on the other side. Okay, so if you have that as your maximum, so that's the what. That's the what are you trying to do. The service solution is how. So the minimum is to refurbish the existing tracks. Okay. The intermediate would be to refurbish some of the existing tracks, but build new tracks in some areas where there wouldn't be enough. And the maximum would be to build a whole new line between London, Birmingham, and for the so building a whole new line. Okay, so the minimum is using existing, intermediate use a mix of existing and new, and maximum would be building new. Now they're interlinked but also independent. Okay, service delivery is who. So it can be a local contractor, a national contractor, an international contractor. It's interesting to see when you look at option appraisals for service improvements or increasing a service. The who is very important. So who do you need to staff your whatever service increase you're doing? Do you need a consultant? Do you need a registrar? Do you need nurses? Is it a nurse practitioner? What banding? Do you need healthcare assistants? Do you need admin support? The admin support is often forgotten. I'll say that. Yeah, when you're increasing your throughput, your clinics, whatever it is, people often forget the admin support and the increased burden on admin support. So when you're looking at who, you've got to factor all of those things in. When we looked at pre-assessment, we looked at a pre-assessment program to bring it all in-house. The who would be a pre-assessment nurse. The intermediate would be a pre-assessment nurse and a group of pre-assessment nurses and an anaesthetist. The maximum would be to try and do pre-assessment from a point of view of pre-assessment nurse. You have your anaesthetist to kind of do any queries. You have your therapy teams to start the discharge planning before they even get into hospital. Okay, so that will be your maximum. So who can be a very big area to do. When is all about timing. So how are you going to implement it? So are you going to do it as a staged system? So you're going to build the first bit first and then the second bit. So in the HS2 scenario, you can do London to Birmingham, Birmingham to Manchester, and then Manchester or Birmingham to Leeds as separate legs. Are you going to build them, multiple areas at a time? So you're going to build from Manchester and from London and meet in Birmingham, or from the kind of ends and meet in the middle, or you can do maximum and build them all simultaneously. Okay, so you can do it as a one by one, multiple at the same time, or all at the same time. And that's the kind of big and for our kind of service improvement projects, it's either a big bang, everything happens at the same time, a gradual rollout, or we do a pilot project in a small area first. So you can look at your implementation. Funding is often who's going to fund it. Is it going to be from existing budgets? Is it from external budgets? Is it from increased budgets? Or are you looking for something else? That's where that comes in. And take a quick few seconds to kind of catch up. So as I said, this is a whistle-stop tour because this often takes me an hour to go through it in detail, but I'm going to try and whip it through it in half an hour. But essentially, that is the strategic case. The economic case is it found value for money, like we said, what options have been considered and which option has been chosen and why. You have to justify why you've chosen the option you've chosen, why you've disregarded the other options. Okay. The procurement process, as you know, is you have to liaise with procurement, because there are lots of procurement rules depending on the value of whatever you're trying to buy. Okay, it's also important to factor in existing contracts. Okay, so if you're trying to buy, so if I'm trying to buy a new pump for what I want to do, but I know that the trust has the organisation has a trust-wide contract to provide, for a particular company to provide these pumps, it might be difficult for me to do that. You may not be able to go through your preferred provider. You might have to do through a kind of an evaluation process, and you have to evaluate 2 or 3 different companies' offerings before you can choose the right one. So there may be various different ways you have to go through the procurement process. Personnel requirements, again, it's often worthwhile linking with HR or people partners to look at your personnel requirements, because for example, if you want to run a clinic 52 weeks of the year, you need more than one person, because a standard consultant contract is generally for 42 weeks of the year, particularly when you're looking at funding. You're looking at 42 weeks of the year for one consultant. And the similar thing with anybody on the agenda for change contracts. They are based on a 37.5-hour working time equivalent. So if you are trying to staff something for 7 days a week or 5 days a week or 24/7, you have to factor in, you have to multiply it up by X number of working time equivalents, and that's where HR will help you with that. Contract issues are, as I said, may be related to procurement, but it also may be to compatibility, particularly with IT systems. So we've had issues where we bought a bit of kit for a machine to help with evaluate people's fitness for surgery, a cardiopulmonary exercise testing machine, and it has a built-in computer in it, but it doesn't. So I mean, the built-in equipment, let's say, was Dell, and our contract with HP. They had issues with ensuring they join the network, and then the safety protocols and security issues related to the software drivers and all that kind of stuff. So there can be equipment issues and stuff like that. How you're going to pay for this, as I said, is all about where the sources of income are going to come from, and who's going to be funding it, which departments' budgets they're going to come out of. If you are suggesting that you're going to make savings, over how long is this going to be, and what are the risks around it? So if your savings are based on you delivering 100 cases per year, what happens if you deliver 75? Are you going to make or lose money? What happens if you do it for 125? Are you going to make or lose money? So you've got to factor in a bit of sensitivity as to underperformance and overperformance. And in the same way, activity will also help you determine in the procurement process, because when you're buying bits of kit, you want to look at the whole life cost of the kit. So an example is that you often get an upfront cost, and then you have consumables. With a lot of kit, you have your upfront cost and consumable cost, and depending on how much you're using something, will determine which one is better. So an example we have that I use is we have bronchoscopes. So we have little cameras that you look in, and we can help intubate, or we can look into lungs, or whatever it is, and they're disposable. And so you have the camera itself, and you have a screen that goes with it. One company might say each screen costs £300, but the bronchoscopes are £50 each or £100 each. Okay. Another company goes, well, we'll give you the screens free, but the bronchoscopes are £300 each. Now, depending on how much you're going to use them, will determine which is the better option over what time period. So the one that gives you the screen free may say that you get screens free. This is how much do you have to pay per scope, but you also have to commit to buying 30 scopes a year for 5 years. Now that's fine if you think the scope's going to last 5 years in terms of technology advantages. What you don't want to be doing is then being stuck with a scope 5 years down the line, where 3 years ago an even better scope has come out that actually which shows marked benefits. or you have to have caveats in that contract that goes, actually, if something better, if you offer something better, we want to switch to the better one at the same price or a similar price, or be able to reevaluate. Okay, so this is where all the kind of the nitty-gritty comes into it. And then finally, how's it going to be delivered is, again, all about how you're going to implement it. What are you going to do in the meantime? What are your backups? What if you are bringing out something, but there's some IT problem and it fails, or if there's a delay in implementation? What are your kind of mitigations for during the implementation process? So when we moved to, well, it's probably a couple of years ago now, but we've done a massive reconfiguration where we moved services across multiple sites. And so there was a period where we had to move our renal transplant service from one site to another. And I think we asked one of the other hospitals in the region to cover the transplant service for 24 hours while we had some logistical issues. And we've done that when we moved our peds cardiac surgery services from one site to another. You can ask another site to take on your emergency activity for that 24 or 48 hours that you might need to do that. So what is the impact on service delivery to make sure that your quality of care is maintained during that period? Okay. And you're also looking at what your impact on service delivery is by, so if you're increasing your clinic here, does that free up space somewhere else? Which means that there's a knock-on effect that's of benefit. Okay. Wow. Okay. So some general tips. Try and engage as many of your stakeholders, anybody that's going to be affected or by your business case, get them on board, get their feedback, make them part of the solution. You don't want barriers, either in the business case process or during implementation. You're better to incorporate their suggestions, address their concerns, get their support in. There is generally a resistance to change within the NHS, and but it's much easier if you make them part of the process, address their issues. Don't try and do it on yourself. The best business cases are collaborative efforts with HR, finance, everybody on board and supporting it. Okay. You need your clinicians, you need your finance, you need your operations teams, you need your HR. Okay. All of them need to be on board to help develop this. Some tips. Timing is important. You might find, and it depends on every year slightly different, but smaller business cases tend to be able to have found successes towards the end of the financial year, where there's little bits of extra pots of money, surpluses here and there, depending on the nature. So again, I found there was some extra sustainability money towards the end of a couple of years ago, which I used to buy the pumps, and that came from the ICB rather than from internally within our hospital. New services funding, particularly if you want to get it from the commissioners, often starts from the start of the financial year, and then discussions can start as early as previous November or before. So you need to get on board early with those, and it's related to the operational planning guidance that comes out. Make sure you're trying to look at the appropriate source of funding. Think about digital transformation funds or education funds. So we managed to get some digital transformation funds for implementing e-consent and digital pre-op assessment. I know people have managed to get funds for renovating of estates, so providing facilities for training from education funds. Think about whether you need, currently there is that differentiation between system funding, so ICS funding and specialised funding. Obviously, in the future that may be less of a difference, but who's going to benefit more? Who do you need the funding from? Is it for system patients, or is it for specialised patients? In which case you might be better off going to specialised funding commissioners. And finally, combine with a larger business case, interlink business cases, or if you've got a big business case going through and you have something that's linked, then you're more likely to get it approved if you put it into the bigger business case. Because if you've got something like a £50 million new build coming along, then actually a few thousand, tens of thousands of pounds for a few bits of extra kit, providing it's justified, is not, it's small fry in that case. What we found in business cases is that ones that can really be negatively impact your business cases are diagrams that are not explained properly. So this was, I had to look at a business case, and this was something that I found, and it doesn't really mean anything. Perioperative care impact, I'm not sure if that's a good thing or a bad thing. I don't know what kind of timeline this is, or what the units are. So it means it's causing more confusion than actually provides clarity. Diagrams need to provide clarity and illustrate stuff rather than make it more confusing. Again, this is something that came up, but actually was irrelevant. I think it was just copy and pasted into the business case, but it was actually irrelevant to the business case itself. This was to do with digital transformation, and I didn't even understand what all this meant. And even though I was, I'm an anaesthetist and actually responsible for some of this, it doesn't really make much sense to me. So again, diagram, if you're going to use diagrams, that's great, but make sure it actually is useful and illustrates your point rather than detracts from it. The ideal business case needs to have the problem being addressed, or the intended benefit is evident. You need to show that all potential options, including ones that you kind of dismiss offhand, have been considered, and there should be a comprehensive rationale for the preferred options. Get people involved, show value, make sure you've got a feasible implementation plan, a sensible one. You've got some contingency into your business case if things aren't going to plan, and you've got realistic timelines. There's no point saying I want to start something in a month when you're trying to appoint somebody into the role who may have a 3-month notice period. If I want to put a new consultant into place, if I haven't already started the process, process can take 6 months just to get the job advert out, and may take a year before the actual post comes can be filled properly. So have realistic timelines for your business cases. Right, I think when you get the handouts, you'll get some links to some useful bits of material that illustrate some of the stuff that I'm talking about, including templates from the government website, from the Green Book, which is the kind of maestro, the kind of not the maestro, the kind of the Bible for all things business casey. I've missed a lot of the comments, so yeah, sorry. HS2 was the high-speed trains, if you haven't caught on. So much information, accurate and concise. Just it is a bit like Dragon's Den. You've got to pitch it in a way that you're selling your bit, and you need to show why yours is better than others, because obviously a lot of the committees get in multiple business cases, all are very valid. It is all about showing your business case is better than others, essentially. Okay. So you're looking at the next question, finance, procurement, and your working groups. Anybody that's going to be affected by your business case should be in your working group. So when we were looking at procuring a new theatre management system, we looked at everybody from waiting list, people who are on the waiting list, people who were sending out the letters, people who were the theatre, people in theatres, the anaesthetists, the surgeons, everybody that might be affected by the recovery people, the discharge processes, the IT, all those people need to be involved, because they may have a say in how it's going to work. And the more people you've got involved, the more opinions you've got, the stronger your business case is going to be. I'm just trying to read through all of this. Yes, NHS England Web Fund. They come out in cohorts, though. The digital transformation funds come out in lots of different cohorts. So you just have to keep an eye on things. Okay. The standing, I know a lot of people have left now, but the standing offer that I make is I'm happy to look at any business case and offer some advice. It may not be, it'll be very much a based on what I've said today and give you some advice. I can't give you solutions and can't actually write the business case, but I can happy to sense check them and identify any pitfalls. We have done previous business case workshops where people pitch their business case and I kind of help them work through it, and happy to do that in the future. Please email either me or the One NH Finance team to if you want to do a kind of a workshop type thing for multiple people and you can learn from each other. If it's just a look at business case, I'm happy to do that. I've looked at a number over the years and can provide some and help on that. You will get the slides. I apologise, it's run over. I know it's a long day. Thank you very much for attending. Any questions, please let me know. I'll hang on for another 5 minutes. You'll get a feedback form. You'll get so please let us know if there's anything else you'd like to learn in future events. We want to do a face-to-face one where we build on the kind of basics from today and to do the next level. And we'd like to know what you'd like to know from that. So if there is anything you want to know, please let us know. I'll hang on for a few more minutes if you want to ask any questions, but otherwise, thank you very much. Enjoy the rest of your week and goodbye.
Thanks, AK.
Emma.
Hi, AK. Sorry for the